I'll call Ravi, I think.
Yes, sir.
Ravi?
Yes, sir.
Recording.
Yes, sir. I'm there, sir.
Very good evening from Auto TV. Today we have Indian Orthopedic Association's webinar on plaster techniques. Now I request Manisha to start the webinar.
Yeah, I request Dr. Raj Gopalan to please give his opening remarks and introduce the faculty. Dr. Raj Gopalan, please.
Thank you, Manish. Good evening to all of you. First of all, welcome to all the people who are logged in, and welcome especially to the postgraduates. We have been doing this e-platform modules. This is the 10th module and probably a very, very important module on plaster techniques. And I'm sure all of you will benefit. It will be done by a very experienced team. And I'm sure that you will definitely learn something. It is as good as all the modules that you had so far. On behalf of the Indian Orthopedic Association and the PG Training Committee, I welcome you all. And it is my pleasure to introduce the faculty to you and also our team of the office bearers and the team behind this program. I stand before you as the chairman of the IOA PG committee meeting, and I will not be the moderator today. Moderator will be Dr. Rajesh. And this is our 10th module. We have all had the clinical modules, and I'm sure you have benefited from that before. This is our organizing team. I will be very brief about it because we have a long program before you. Dr. Meena, our president, this whole module, whole platform, all came from his inspiration and idea and support. Is the president of IOA, and all of you know Dr. Shivashankar, president-elect, Dr. Ramesh Sen, the vice president, Dr. Lalit Maini, he is here, he is the editor of IJO. Dr. Lalit, welcome. Dr. Sandeep, joint secretary, and Dr. Sanjay, joint secretary. My team, along with me, my committee includes Dr. Shah from Bangalore, Dr. Ray, and Dr. Rajesh Goyal. And also in the team, the webinar coordinator is Dr. Manish and Dr. Ravi. Both are the people really, the entire program is on because of their coordination. Dr. Ashok, Dr. Neeraj, and the people who are able to broadcast this and their team are helping us to broadcast the whole program to you. We have today very, very senior faculty. Dr. Rajesh Gupta, he has done this program many times before and has been with his team and has had a wide acclaim. And we have a very, very senior person, teacher of all of us, teacher of teachers, Dr. Taneja. I don't have to say anything more, but few words will come. Dr. Rajesh, Dr. Mukherjee, Dr. Venkatesh Mulimani, Dr. Atul, Dr. Sanjay Swarup, Sandeep, and Dr. Manish Dhawan. Dr. Taneja, as I told earlier, he is very well known. His teaching programs are known. Past president of our association, and I think everything about him cannot be told. We don't have time, but sir is known for his interest in academics, in the world orthopedic concern. Yes, he has traveled throughout the world. He is very well known everywhere. We cannot forget the IOA Congress presidency. Sir, welcome, sir. Dr. Rajesh, he is the head of department, professor of orthopedics at Jammu, and he is also secretary of the Jammu and Kashmir Orthopedic Association. He is a member of Rural and Social Orthopedics. He had done his fellowship in arthroscopy from AIMS. He is a fellow of sports medicine. In fact, Rajesh wanted to do a PG teaching program because of COVID. Live, we could not do it so far. Welcome, Dr. Rajesh. Dr. Amitabh Mukherjee, he is the chief orthopedic and the chief of the orthopedic and joint replacement clinic in Baglati. He is the project manager of the SIGN project, which is known to you all. He is a Shushruth Award winner in IOCON 2004. And also, he had the Ponseti Bakshi Medal in IOCON 2007. He had the best dissertation for his MCH. He's also delivered the Silver Jubilee oration in 2010. He has presented numerous lectures at various prestigious platforms. He has numerous publications and his field of interest is joint replacement and trauma. Dr. Venkatesh Mulimani is the professor and head of the Department of Orthopedics in Kubsli, Karnataka. Dr. Atul is a senior consultant orthopedics in Islamabad and is the field of interest is trauma. He is also a member of the Medical Legal Act Committee of IOA, very active member of that particular committee. Sanjay Sarup is known to all of us. He is the director of the Children's Orthopedic Center and Spine Surgery at Artemis Hospital, Gurgaon. He is a faculty and in charge of the DNB Orthopedics program at Artemis Hospital. He is actively involved in clinical research. He runs a 2-year fellowship program in pediatric orthopedics. He is trained in various centers of excellence, and his special interests are DDH, scoliosis, limb thinning, and congenital deformities in the upper and lower limb. We have 2 pediatric orthopedic specialists in this module. The second one, Dr. Sandeep, I think he is very well known to all of us who have interest in pediatric orthopedics. So many times I have taken opinion from him for so many problems. He is the president of Pune Orthopedic Society, secretary of the Pediatric Ortho Society of India. He is a honorary visiting pediatric orthopedic specialist in Bharti Vidyapith Hospital. He is also the chief pediatric surgeon of cerebral palsy projects. He had a vast teaching experience and he has got excellent video demonstration of many pediatric orthopedic problems. Dr. Manish Dhawan is also the webinar coordinator. He is the treasurer of India Orthopedic Association. He is the president of Assami India. Recently had a very successful Assami meet in Delhi. He is a professor at the Gangaram Institute of Postgraduate Medical Education and Research. He is also a senior consultant in the Department of Orthopedics. His special interests are complex trauma and limb lengthening and deformity correction. I'm sorry if I left out anybody by the slides were moving in between. And I also welcome all others who are involved in this matter. And thank you all and wish you all a very useful session. Thank you.
Raju Balan, sir, am I audible? Or...
Yes, sir. Yes, sir. Yes, sir.
Yes, sir, you are audible, sir.
Okay, thank you. My video is not there.
Dr. Rajesh, you can start now.
Sir, please carry forward, sir, Rajesh, sir.
Dr. Rajesh.
Yeah. So I think I must thank all the faculty, for coming together for this plaster technique webinar. We have to postpone it once because of, Dr. Taneja was not well, but now we are on, here, all of us are here now. We have excellent faculty today, and I must thank the IOA PG committee also, for allowing us for this webinar, and to you, Manish, and Ortho TV also. We are very thankful that plaster is now picking up. We have already done around 7 to 8 workshops all over India for the last 2 years, and the more programs were there, but due to COVID, I think we could not do the programs. So now we thought, let us do in this online fashion. So thank you very much. So we start with the things now. So I think first talk is by Dr. Amitabh Mukherjee, sir. Dr. Amitabh?
Am I audible? Thank you.
Yeah. Share your screen, please.
Yeah, I'm trying to share it. Is this visible now? Is this visible now?
Visible. Carry on.
Yeah.
Carry on, sir. Sir, put it on slide mode, please. Yeah.
Yeah, this is okay.
This is okay, but this has run very fast. Why? I
No, no,
don't
no,
know.
no. Hold your hand.
Yeah, that's fine.
Yeah, it's fine.
It's fine. So, good evening, everybody. This is nice to see all my seniors, my friends, and my respected teachers also here. So today I have a basic duty to say something about fracture healing, which is the basic part, and this is a PG training program of IOA. So that becomes my mandatory duty to say some basic words about the fracture healing. So as we all know, that a definition of fracture, it's a break in the continuity of the bone. It's partial or total disruption, the blood supply of the region of the bone. Seen radiologically, it may be uni or bicortical one. So it's a basically it's a systemic and organized cascade of events for regeneration of tissue with influence of local and systemic factor. So it's a fracture repair. It's a regenerative process after then healing, as the defect is replaced by new bone rather than a scar tissue. A new bone has to be formed. So it is a continuous process in which formed, replaced, and remodeled. So these are three consequences on which the fracture is being healed. So the local factors are also influencing this. What are the local factors? The type of the bone, type of the fracture, intra-articular fracture, surrounding soft tissue injury, single or both bone fracture, local bone pathology like cyst, infection, venous stasis, type of treatment, I mean like fixation, what you are doing, they all influences the fracture healing. So systemic factors are also important, like age, activity level, nutritional status, hormonal factor, vitamin, mineral deficiency, diabetes mellitus, patient on drug like chemo and steroids, and smoking, alcohol abuses, and head injury. They also influence for fracture healing. So types of fracture repair are basically three. One is intermembranous or direct bone healing. Next is creeping substantial. Third is repair with bone callus formation, which is indirect bone healing. So coming to the intermembranous repair, it's no callus is basically formed. Bone heals directly. It's a rigid fixation such as plating that leads for such sort of healing. This occurs when gap after fixation is below 500 microns. Cutting cone crosses from one side to another side, and that's the way this bone heals. Intermembranous repair has generally following stages. One is reabsorption of the bone end. Second is fibrous tissue formation. Third is the maturation of the laminar bone. The Haversian remolding occurs across the fracture side, and osteoclast follows the system, and the osteoblast ossification and laying down thin capillaries. That is why and how it is healed in intermembranous repair. So there is creeping substitution. What is that? That's the primary seen in cancellous bone, seen around the intra and periarticular fracture. It's process of reabsorption and trabecular network, lying a new bone of the opposition and the surface scaffold. The inflammatory cell and the granulation tissue, they creep, and the new bone is thus formed. And thereafter, the sandwich of necrotic bone and the surrounding by the viable new bone is remolded. The gross architecture of this bone is maintained. The scaffold is down just like other copy and pasted in the new live bone. The secondary bone healing, this refers to the passing through the stage of callus formation. Callus is pre-ossification of cartilage tissue, which is formed in response to the control motion over the fracture site. So the bone healing is basically of three stages again, as we all know: reactive or inflammatory stages, where there is hematoma formation, there is granulation tissue formation, and there is reparative stage, where the callus is formed basically of these two types. One is soft callus, another is hard callus. Then comes the stage of consolidation. Then comes the stage of remolding. So in flow chart, inflammation, repair, soft callus, hard callus, and remolding. Thereafter, this graph shows us the stage of fracture healing, where the inflammation currents 10%, reparative phase and 40% and remolding around 70%. And there is interaction of the both curves in many places where both of them takes one after another. The hematoma formation in the inflammatory stage, the blood leaks into the surrounding tissue due to the disruption of the vessel and the periosteum and endothelium and induces local inflammatory response and starts regional acceleratory phenomena. After which the stage of hematoma formation comes, where osteoblast comes from the bone marrow and mesenchymal cell from the cambidium layer of the periosteum, and the osteoclasts come from the hematopoietic cells of the bone marrow. They both are being influenced by BMPs, migrate to the fracture focus. The TGF beta and the platelet that derives growth factors. The colony is formed using the fibroblast, and the granulation tissue mass is being formed. This granulation tissue mass has an hematoma and has the vessels, splitting vessels thereby. The vascular endothelial growth factor and the fibroblastous growth factors come in picture. The fibroblastal granulation tissue makes the type 2 collagen, and this stage lasts for 2 weeks. And thereafter, the reparative stage starts. It composed of 2 stages, as I say, callus formation. One is soft callus, another is hard callus. And then comes the consolidation. The callus formation, as I told, this regenerative tissue formation responds to the micro motion of the fracture site. The formation combines effect distinct healing response. They are from bone marrow, they have from bone cortex, they have from periosteum, they have the external soft tissue, which also plays an important role. The soft callus start forming in the 2nd week. There are 4 types. One is periosteal bridging callus, another is intramedullary callus, another is intercortical uniting callus, another is external soft tissue callus. These are the calluses. So periosteal bridging callus cells from the cambidium layer develops into the osteoblast and deposit in the organic matrix. The intramedullary callus lays down from the inner side of the bone. It's double the convex type and primordial response during the gap repair. And this intercortical uniting callus occupy the space between the opposed cortex of the fracture end. The external soft tissue response develops from the vascular mesenchymal tissue like muscles, and it is important in fracture repair. So reparative stage, the hard callus transformation of woven bone to the primary laminar bone. As you can see here, the comments is from 4th week, that bone deposition. The type 2 collagen, as I said, is replaced by type 1 collagen and followed by mineralization.
Dr. Mukherjee, we can't hear you.
There is some problem.
Of this
Dr. Mukherjee,
collagen
Dr. Mukherjee.
Osteoid. And yes, sir. Yes, sir.
Dr. Mukherjee, actually, we lost your communication, so you can go to the previous slide once and then start again. Just previous slide before this, because we could not hear you. Just a slide before this.
Okay, sir. How much, sir?
Yeah. No. After this, next slide. Dr.
This
Mukherjee.
one, sir. This one. This one, sir.
Next. Yes. This one.
This one, sir.
Yes.
So the hard callus, the transformation of the woven bone in primary laminar bone. The commencement is from the 4th week and finishes around the 16th week. The amount of callus formed depends upon the oxygen tension and the strain pattern, and I mean the treatment which has been given for the fracture. So the consolidation is the laminar bone, the lamellar bone deposition. The type 2 collagen replaces by the type 1 collagen and followed by the mineralization of the collagen, which has been taken care by the osteoid. The endothelial ossification, the formation of the laminar bone over the hyaline cartilage, the bone substitution, the formation of the laminar bone over the woven bone. Thereafter, the recycling remodeling of the mineral
Again, the voice is gone.
Hello.
is taking. Am I audible? Am I audible, sir?
No, sir, is just
No.
start the slide from the beginning, this slide, remodeling slide, because we lost your communication. This
So
slide
where
only.
from?
Yeah,
So where
from the remodeling only from the beginning. This slide from the beginning.
Where?
Some net problem.
Yeah.
Is that okay? Is that okay?
Yes,
Very
sir.
well.
Yes, sir. Yes, sir. I think there is some, Wi-Fi problem from his side.
You can switch off his video, it might help.
Manish, I think even that video is still.
Yeah, I think we lost him now.
Hello.
Dr. Mukherjee, can you hear us? I think we lost him.
Yeah, it's like a bad connection at his end, I think.
Call him on his mobile. Hello,
Yeah.
everyone.
Yeah.
Yeah.
Dr. Rajesh, can you call him? Dr. Rajgopalan,
Yeah.
I think we go for the next lecture and he can join it later on.
Yeah, because his video also stalled. I think
Yeah.
Dr. Rajesh is moderating, I thought.
Dr. Rajesh.
Yeah, sir. I'm just calling him
Yeah,
up.
that is better to save time.
Yeah. No, कुछ नहीं आ रहा अभी. दोबारा से स्टार्ट करो ना उसको. हाँ, दोबारा जाओ.
Meanwhile, we can welcome Dr. Ray, Dr. Shah, who were joined after that. Thank you, Shah. Thank you, Dr. Ray.
Thank you, sir.
Thank you, Dr.
Better he should.
So 1 minute only, just wait. Yeah.
Dr. Harshad, good evening. Dr.
Okay,
Ray, good evening.
Okay. Dr. Manish, you
Yes.
start with your lecture.
Okay.
We continue later on, if it connects.
Yeah, so we go to the second lecture. I'll share my screen. It's one of the most basic lectures. So my screen is visible?
Yes.
Yes.
Okay.
Yeah, go ahead, sir, please.
Yeah, it's visible.
So my topic is Plaster of Paris and recent advances. So Plaster of Paris is the baseline of the basics of all the fracture reduction. So I am Dr. Manish Dhawan and I am senior consultant at Sir Gangaram Hospital, New Delhi. And I'm also a professor at Gangaram Hospital that is known as GRIPMER. And I also was treasurer of Indian Orthopedic Association till 30th July for 6 years. And I'm also president of Assami, India. So, cast immobilization of fracture allows for undisturbed healing to occur. So, when the healing process, as Dr. Mukherjee has told, so it is very important that for fracture healing that there should be immobilization. So, it helps in that. And immobilization methods have been evolved over a long period of time, from wooden splints to POP cast to 3D cast and wood cast. So, it's a total evolution over centuries. An application of cast is the most common method of rigid immobilization of fracture, which has been practiced since many centuries. Now, purpose of casting is to provide immobilization of fracture when the fracture occurs. So we want the healing to occur, and to protect the injury, further injury, and the injury means if it is not immobilized, the fracture ends, they can bleed again and there can be again soft tissue injury. So it protects that. And most important thing is that once you apply casting and give stability, the pain of the patient or the fracture side decreases. Now, POP was the mainstay of treatment as the casting material until the recent increase in use of synthetic cast and other advances in casting like 3D cast and wood cast. So now I'll take you to Plaster of Paris, and it has a very interesting history. And sometimes And very often during the ward rounds, the students are asked about the history of plaster of Paris. So certain important thing they should know, and it's a very interesting history. Now the whole credit of this plaster of Paris bandage goes to this Dutch army surgeon Anthonius Mathieson. He was the first one who used impregnated cloth to form rolls like plaster bandages what we have. So this was basically he did in 1852, and after 1852, even in the World War One, the fracture casualties decreased considerably. So it was all the injuries were immobilized and lot of lives were saved. So even in First World War, lot of lives were saved. Now timeline and casting is basically goes till the period of Hippocrates, the father of medicine. And this is around 350 BC when he used bandage stiffened by waxes and resins to treat fractures. And in 1860, Rhazes in Arabia used lime and egg white to stiffen his cast. So this is a kind of a small manuscript with this. This is a description by Rhazes. So in 1756, Chalcedon, an English surgeon, used bandages soaked in egg white and flour to form cast. In 18th century, in Turkish Empire, which is also known as Ottoman Empire, plaster of Paris was used for fractures. Limb was enclosed in a case of plaster, and any space which appeared as swelling subsided was filled with pouring plaster cream through the hole in the cast. So they used to first apply cast. When the cast became loose, again they used to fill it with the gap with a plaster of Paris. Now, 1816, Hubenthal improved upon the previous idea of mixing plaster of Paris and minced blotting paper in equal proportions. Now, in 1828, Koyal and Klug in Berlin used a wooden box in which they rested the limb. Then they poured plaster of Paris cream into the box until the limb was nearly covered. So now we come again to the contribution in 1852, Anthonius Mathieson, which I have already told you. These bandages were made by rubbing dry plaster of Paris powder into coarsely woven cotton bandages, which were then soaked in water before being reapplied, and they had to be freshly prepared before use. And when I joined orthopedics during my junior residency days in Safdarjung Hospital, we used to prepare bandages fresh. We used to take plaster of Paris powder, rub it over the cotton bandage, and roll them. And we used to make them fresh. So it was practice. Maybe around just 20 years back, we used to create our own bandages. Now he published his monograph in 1852 in medical magazine called Repertorium. His plaster bandage was based on principle of Suetin. Suetin 10 years earlier he had introduced starched bandages like which were known as bandage amodini. And Mathieson bandages consist of strips of coarse cotton cloth which finely powdered plaster rubbed on it, and this method was preparation was used till 1950. But I have used till means I practiced this thing even in 1993 when I joined my post graduation. So plaster of Paris bandages are made available to a common man in 1931, and it also received the patent, US patent. Now, if you see this chart, the evolution, you can see that it has been practiced. Casting has been practiced from Egyptian time, like 3000 BC, when they used to soak the cloth of during mummification process to cover the mummy with resins and some materials. So that was practiced. Then the technique slightly matured in Roman period. Then medieval period, lot of bone setters, used to do it. Then in 16th centuries, the artificial limbs were accelerated. So plaster of Paris was used in artificial limbs also. And then came the 19th century when Mathieson, gypsum was introduced and plaster bandages came. Now from 1970s onwards, fiberglass and other casts, the evolution happened. So we will see that in our coming slides. Now, this is very important. This is a very short story because it is sometimes asked in the ward rounds. So what is the story behind the plaster of Paris? So name is said to stem from an accident to a house built on a deposit of gypsum near Paris. So it was on a gypsum deposit was there, and it was a mine, gypsum mine, and the house was over it. It burned down, and when the rain fell, the baked mud of the floors, it noted the footprints in mud set hard rock. So this is the original plaque. So then this was plaster of Paris was discovered. Now, when Henry III visited Paris in 1254, he admired the whiteness of the walls, and they were very polished and plain, and popularized the use of plaster of Paris for walls in England, where it became known as plaster of Paris, platter of Paris. So later it became plaster of Paris. Now, plaster of Paris composition and formation. Now, gypsum is first heated to drive off water. When water is added to it, resulting powder, the original mineral reforms and heat is released. Like the powdered form is first heated, and then when water is added, then the chemical reaction happens. So calcium sulfate dihydrate plus heat is the original gypsum, and calcium sulfate hemidihydrate plus water, when water is mixed. So calcium sulfate hemidihydrate is known as plaster of Paris, and this is a exothermic reaction. So this everyone knows it, and this is a very important this thing. Now, modern plaster of Paris bandages are made of by grinding the gypsum and then heating in steam pressure autoclave. The powder is suspended in a volatile solvent with various additives to improve handling characteristics. The resultant slurry is coated onto special interlock woven cloth, which is known as limo. Now, after that, the solvent is removed by drying in an oven. So once the solvent has to be removed, and after which the bandages are cut, rolled, packed in a moisture-resistant containers. So this is the way the plaster of bandages are, produced. Now this is kind of a picture of the bandages which we use every day as a commercial bandage. Now, setting time to convert powder to crystalline form, it varies with so many factors. Factors which are decreasing setting time is hot water. If water is hot, the POP sets very fast. If you add salt, if you add borax, if you add resin. Now, factor increasing the setting time are cold water and sugar. Now, drying time. Time taken for plaster of Paris to convert from crystalline form to anhydrous form, influenced by ambient temperature and humidity. So humidity and temperature has a very important role. If temperature is high, then plaster will set very fast, and if humidity is high, also it will set very fast. The optimum strength is achieved when plaster is completely dry. So what are the advantages of plaster of Paris? It is cheap. It is easily moldable when wet. Now it has certain disadvantages also. It is heavy. It is partially opaque. It has a long setting time. It has a messy application. You can spoil your clothes, and all in the room you can have a lot of mess. It has a low strength to weight ratio and high water permeability. So you have to protect this with and low temperature thermoplastic orthoplast. So these are the latest advances. Now, what is an ideal casting material? So everything boils on that which is the best casting material. But now ideal material has been not still found out, and it is still evolving and improving day by day. Now, ideal casting materials should be suitable for direct application to the patient. It is easy to mold. It is non-toxic to both patient and user. Unaffected by fluids such as water, it should be washable. It should be transparent to X-rays, easy to modify. It should have a quick setting time, easy to remove, able to transmit air, odor, water, pus, means any collection, it should be freely, it can come out. It should be strong but light in weight. It should be non-inflammable. This is very important because certain synthetic materials, they can, catch fire. It should have a long shelf life and it should be cheap. Now, synthetic casting tapes has been commercially available since late 1970s. So discovery of water curable resins made synthetic casting tape a commonly applied product. So like Scotch cast and fiberglass, which we use daily. Delta cast is a kind of advancement over it, and is also known as polyester casting tape. Now this is the Scotch cast bandage, and you have to very carefully apply it. And first we apply a stockinette and then soft roll, and the bandages are wrapped gently from down up. So this will be explained how in the next lectures, coming lectures, that how to apply them. So this is one of this thing. Then in case of water activated cast like Scotch cast or Scotch cast chemical as polyurethane pre-polymer coated on fabric. So this is the basically polyurethane pre-polymer coated on a fabric or glass cloth to form bandages. On coming in contact with water or moisture, polymerization process starts and bandage set. So polyurethane pre-polymer plus glass cloth plus water plus moisture, polymerization occurs and bandage sets in. Fiberglass is also known as glass reinforced plastic GRP or glass fiber reinforced plastic GFRP. It is a fiber reinforced polymer made of plastic matrix reinforced by fine fiber of glass. Now, what are the advantage of these new material? It is strong, it is lightweight, it is more radiolucent, it facilitates weight bearing early, it's more water resistant. Disadvantages are high cost and it is less moldable. Now there is a comparison between our plaster of Paris, the generation old plaster of Paris, and the fiberglass. So cost plaster of Paris is very cheap, fiberglass is higher. You can mold plaster of Paris in an excellent way, but in fiberglass, it's an average. You can't mold it much, like it's not as versatile as plaster of Paris. Strength, plaster of Paris is very average, but very good strength, excellent strength is there in fiberglass. Weight of plaster of Paris is heavier and lighter in fiberglass cast. The curing period, 48 to 72 hours, is a high curing period for plaster of Paris. Now, for fiberglass is under 30 minutes. Radiolucency is poor in plaster of Paris, but it is very good in fiberglass. It is water resistant. The fiberglass is water resistant, but plaster of Paris can spoil with water. Skin complication, like once you have applied the bandage or plaster of Paris, once it is dry, you can remove it. You can just you can wash off the skin with the water or with a wet cloth. But to apply fiberglass gloves are mandatory because resin, it can stain your clothes or it can stick to your skin, and it is very difficult to remove, and it can be there for days. It might sometimes in sensitive people, it can cause allergic reactions also. So in fiberglass, yes, but POP usually it is not, no allergic reaction. Now, plaster of Paris spreads easily. You can spread it very nicely and mold it. But in fiberglass, spreads but recoils. Need a wedge to maintain the opening because it is very important. It's a very hard cast. So if you have to have an opening, it is better to make a wedge and make the opening wider because it has a problem of recoil. So it can tighten. Now, what are the hybrid cast or composite cast? It's nothing but it's a application of POP plus synthetic cast. So in this, plaster of Paris is applied as an inner layer and synthetic cast material such as Scotch cast is applied as an outer layer. So it's a hybrid variety. Now, what are the benefits? In this merit, the POP has a super modulability. So you can mold it and nicely the fracture, and once it is dry, then you can apply Scotch cast for superior strength and wear characteristics. So you take both the qualities. You can mold the fracture very nicely with POP, and then you can give the strength to the cast by the synthetic cast. And this can also, in our countries, it can be a cost saving venture, because the fiberglass cars are very expensive to in India. So it can be, a hybrid situation can save a lot of economy. Now, when applying composite cars, the outer synthetic layer should be applied several minutes after the plaster of Paris to minimize temperature rise. So this is very important. Once the plaster of Paris is set, it's hardened, then you apply it. Plaster and fiberglass hybrid cars should be considered for orthopedic use on basis of their strength, stiffness, weight, and cost, combined with their acknowledged advantages of good molding ability and water resistance. So there is another variety, is a advancement which is known as delta cast. It is a polyester casting tape, and it is not a fiberglass. And with polyester casting cast substrate, there is it basically prevents the murkiness and distortion that fiberglass or plaster cast provide. So it is in fiberglass, if you properly you do not mold it, or at the joints you can get some distortion, but delta cast is quite stretchable, so it prevents that. Now, what are the advantages of delta cast? It has a better molding than fiberglass cast. It is water resistance, lightweight, smooth finish, highly radiolucent, working window of up to 3 minutes. It's enough time to mold it, and weight bearing can be allowed after 20 minutes. It has superior strength and durability. Disadvantage is the cost. It is also available in India. Sorry. Now, as further advancement, orthoplast. Now, what are orthoplast? Is the thermoplastic splinting or casting material. This material is used for braces and for processes. So it has been used. So these are inert plastics, and they become pliable when heated and harden when cooled. So you can mold them with heat. The temperature to which these have to be heated exceeds that which has to be tolerated by skin, but since they are poor conductors of heat, they do not usually cause burns as long as the surface is dry, and they are allowed to cool slightly after removal from the oven or water bath. So they are poor conductors of heat, so they do not basically cause skin burns. Now there are two types. One is the perforated variety and one is the non-perforated variety. So heating time is around 2 minutes, or 1 to 2 minutes at a temperature of 70 to 75 degree, or 160 to 170 degree Fahrenheit, or it is 65 to 70 degrees, or 140 to 158 degree Fahrenheit. Working time is 5 to 8 minutes. In some forms, it is 3 to 4 minutes. It is good in durability and moldability. So you can, make it custom made. Now, the era of 3D cast and concept of 3D printing technology and making of personalized cast have emerged in a recent past. To gain a 3D printing cast, technicians can use the image data with 3D spatial information of limb captured by 3D scanner or medical imaging device, and then conduct the computer-aided design to obtain the stereographic format file for 3D printing. So these are basically custom-made casts. So Professor Lalit Mani is also present in this webinar, and he has a lot of work on 3D casts, and he has also brought a small book with Dr. Raju Vaishya. So that is worth reading. Now, these 3D printing casts, if you can see, they are specific to the patient. They can be, opened with straps, or they can be, removed and put it. So it is it increases patient comfort, and also it's lightweight, and also the satisfaction of patient is more because it is quite good fitting. So you can see this 3D printed cast. Now another variety is the wood cast. It's a wood plastic composite made from wood chips, and it is biodegradable plastic. Produced in sheet from compound of biodegradable plastic and wood, making it extremely lightweight and tough at times. So it's a mixture of wood chips and synthetic material. Now in this you have to, these are sheets of available with of wood and plastic, and you have to heat it, and after heating you can mold it, and then you can hold it with a casting tape till it is set, and it is it's also very lightweight, very strong. So advantage of wood cast is it's non-toxic, it is moldable and remoldable. You can reheat and you can remold it. Once if suppose swelling has gone and the cast has become loose, you can remold it. No water or gloves is needed. It is self-adhesive. It is breathable, X-ray transparent, and it is environmentally friendly. Now these are certain wood casts, so it's a kind of a custom made, and you can make splints also, and it's a very it's a recent material. Now there are different studies if you go to the literature. One is in the clinical biomech, a comparative study of strength characteristics of novel wood plastic composite and commonly used synthetic cast materials. So outcome of study is that wood cast is indeed strong enough to be safely used in weight bearing cast applications. So this material is quite strong and it is very lightweight, so very comfortable to patients. So wood cast. So wood cast versus standard casting material for immobilization of non-operatively treated distal radial fractures. So outcome of study is that, this is basically from bone and joint surgery, very recent article. Clinical outcomes and patient acceptability were similar between two interventions, and no serious adverse effect was reported either in any intervention arm. Means wood cast and other this almost the same results, the other synthetic materials. So thank you with this, and I also thank Dr. Raj Gopalan to giving me this opportunity. Thank you.
Very nice talk, Dr. Manish, comprehensive, and you have touched all the latest things, like wooden cast and all those things.
Thank you.
Any comments, questions from the faculty?
Rajesh, can I make a comment?
Yes, sir. Yes, sir. Carry on.
You see, when you talk about the history of the Plaster of Paris, and we talked about the Henry VIII king, and we said he was from 13th century. To my knowledge, that Henry VIII was in probably in the 16th century, and the king of the England, who was living in a Hampton Court palace, he went to Versailles Palace. The Versailles Palace was made by the Louis XIII and then Louis XIV and Louis XV, and that was in 17th and early 18th century. That is where the Versailles Palace, they used the plaster of Paris for the first time. Okay, and that is what the King of England saw, and who was the king of probably James or whatever the king was at that time. And that is he got this idea and got the plaster of Paris. Well done. It's a very informative lecture. Thank you.
Dr.
Mukherjee, wait. Just wait. Any other comments from the faculty? Yeah, Dr. Harshad.
Yeah, Dr. Shah here. Manish, very nice lecture. Very informative. I think it covers up everything. All doubts on the types of materials we can use externally for immobilization other than the splints that we make. And I'm surprised with Dr. Taneja's historical this one. I was in Versailles last year, but I have not seen or heard about any Plaster of Paris things there. Anyway, I'm not a student in history. I always thought that we read history or see history and forget it. Right. Thank you.
Thank you.
Anybody?
Rajesh, can I ask one question to Manish?
Yeah, sir. Yeah, carry on.
Manish, just one thing I'm just wondering. Cost may be a factor in our country, but given the worldwide, how much has been the percentage of reduction? I mean, suppose we had only plaster of Paris cast, say 40 years back. In the last 40 years, how much of the percentage of use of the plaster of Paris cast has been taken away by the synthetic cast worldwide?
Sir, actually worldwide now, POP is the mainstay, even in Western countries. Because I worked in Western countries and I've seen them for initially, the fractures which are very recent, they try to mold it with POP only. They tried avoid using synthetic cast. When the swelling and everything reduces, after a week they convert it into a synthetic material. But mostly, yes, it has reduced, but it is still the backbone. So it's still popular for reductions because you can mold it very nicely.
Dr. Manish, wanted to comment.
Yeah.
It is basically a fiberglass.
It's a fiberglass.
Okay, as you know, the other cast, polyester cast is a Delta. Delta is by a company, a BSN company.
It is like Gypsona. Gypsona is a trademark. It is not.
That's what I'm saying.
All of them common. You can say it is fiberglass.
Yes, fiberglass. Yes.
I would like to make a comment.
Or any of them.
And second is the wooden cast you have mentioned, it's available in India?
No, wooden cast is not, but Delta cast is definitely available.
I know that.
Can I make a comment, please?
Yes, sir. Carry on, sir.
I think one thing that probably Dr. Manish overlooked was that if you apply a fiberglass cast, the nature of the fiberglass is such that it tightens as it sets.
No, I have actually told that you have to make a wedge. It tightens, it recoils.
It tightens, and yes. POP remains the same or loosens a little as it sets. And therefore, POP is a safer option when you have an acute injury. And fiberglass is not a safe option because it can cause a vascular compromise.
Because of the recoil,
Rajesh sir.
Yes, sir.
There is I would want change actually. Sandeep Patwardhan sir has to go somewhere in some emergency at 7:30. So can we shift his lecture just now?
Yeah, I think, can we do it? Okay, carry on. No problem.
Yes.
Carry
on.
After
Sandeep, we will take Dr. Mukherjee's lecture.
Yeah. 5 minutes.
Definitely.
Okay.
No problem.
Sandeep sir. Sandeep sir.
Yes, Ravi.
You can go ahead with your lecture, sir.
Thanks a lot, Ravi. Thank you, and I'm very sorry for this change in plan, and I'm obliged for accommodating me. So my brief was to talk on close reduction and spika in DDH, and for the postgraduates, I thought it would be nice to give them a very clear idea of how we should be doing. Can you see the screen?
Yes.
Yeah, sir. Please go ahead.
Okay. Thank you very much. Thanks for that. Thanks, Dr. Gupta and IOA team and Dr. Rajgopalan for the opportunity. As you all know, the goal of treating a DDH is to obtain and maintain a hip reduction and try to not cause avascular necrosis. That is the prime requirement. So methods of close reduction. Traction and gradual reduction method, which the Japanese follow, is published by Kito et al. You can start with several weeks of distraction in linear fashion, followed by an overhead abduction bar, and then again continuing traction till gradually the hip reduces spontaneously. So here what you are doing is you are achieving reduction by traction itself. This is what we rarely follow, is more historical, but Japanese still follow it with good results and they have published it. What most of us do is close reduction and hip spica cast under general anesthesia with or without a few days of preliminary traction. So what are the indications for doing a hip spica in a child? A dislocated hip between 6 months to about 18 months of age, which is untreated or has tried a Paulik harness and has failed to get reduced or is unstable. Less than 6 months may have a higher risk for anesthesia. And a few papers have also said that because the head is so soft at a very young age, too much force or compression on the head may lead to avascular necrosis, and they feel the AVN rates are higher. In fact, a few papers have asked people to wait till the ossific nucleus appears so that there is some hardening of bone and AVN rates are lower. But there is a controversy regarding that. Preliminary traction may increase the success of your close reduction because you are stretching the soft tissues by pulling the head to the line of the Hilgenreiner's line so that you can then give the abduction maneuver or the Ortolani maneuver to reduce it. And this may actually decrease the AVN by decreasing the pressure on the head by soft tissue tightness, and the adductor tenotomy may not be needed. So it's a good idea to give 5 to 7 days of traction in something like this, either overhead traction with something like a gallows But these kind of traction need intensive monitoring so that you don't create a compartment syndrome. The idea is to bring the hip to the level of the Hilgenreiner line, and then you do your Ottorani maneuver to reduce it under anesthesia. What are the steps of plaster treatment? Under general anesthesia, always to be done under general anesthesia, a gentle reduction with the Ortolani maneuver, and then you assess the reduction by two methods. First is you must document your reduction with an arthrogram. Just a click is not enough. And then you must assess what is the safe zone. I'll come to that. If the safe zone is very narrow, that means the hip is easily redislocatable, and adductor tenotomy may be needed, which will add to the ease of reduction. Make sure that when you give the plaster, it is in the human position. All papers who have shown that abduction exceeding 50 degrees or internal rotation exceeding 15 degrees have a higher propensity to avascular necrosis. A 1.5 or a double hip spica may be required as the situation demands, but it is important to document reduction in the cast by proper imaging technique, which I will come to again in a minute. So as I said, it is very important to assess the reduction. This is the most important part. Only a clinical feel of ease of reduction is not the only criteria. The stability should be checked with dynamic examination. So abduction at reduction and dislocation should be judged, and you have to look at the safe zone of Ramsay. Make sure that it is stable in the human position, and an arthrogram will tell you the depth of reduction. So that is the safe zone. Typically, if the safe zone is very narrow, that means with a little maneuvering, the head pops out again. It's an unstable reduction, and probably you need to add an adductor tenotomy or bring the child back for a medial open reduction if there is something obstructing your reduction on your preliminary reduction maneuvers. If you have to increase abduction beyond 50 degrees, again, that is not a good idea because you're going to end up with AVN. So you must get reduction between about 20 degrees to 50 degrees of abduction, about 90 degrees of traction, 90 degrees of flexion, and very little or zero external internal rotation. Reduction pitfall, like I said, is a click enough? A click is not enough. And this is the dynamic examination which has to be done on arthrography. If you see this dislocated hip with an arthrogram, there is a medial die pooling. These are the two parameters that have to be seen. How much is your medial die pool and what has happened to the rose thorn? So I'll explain what is the rose thorn. The normal medial die pool should be less than 2 millimeters. As you can see here, it exceeds about a centimeter. So the hip is definitely dislocated and you don't see a rose thorn here, which is blunted or because of eversion. Now look at this image. When I reduce the hip, I can demonstrate a beautiful rose thorn. The rose thorn is the sharp edge of the labrum which is seen after an arthrogram on a concentrically reduced hip. You see the medial die pool has disappeared and you get a superb rose thorn and there is no blunting here. What you see from here to here is the cartilaginous acetabular rim, which will eventually ossify. So dynamic examination and documentation of a rose thorn with a die pool less than 2 millimeters is mandatory before you start your casting. Again, this is an arthrogram demonstrating poor reduction, which shows you a blunted rose thorn and an excessive medial die pool, which shows a block to reduction. When you give the spica cast, you can use a lot of materials for padding. Most of the places abroad use a small Gore-Tex liner. It's like a bubble wrap. They have air-filled small kind of a bubble pellets, which give a sort of a spongy protection. They are waterproof. So they use a spica table with an abdominal space is created with a small towel. I use an arm board. I'll show you the arm board technique in a moment. You hold a reduction in the human position. On the Gore-Tex liner, you can put your soft roll or soft cast padding. Always pad the bony prominences, the iliac crest, around the malleoli, around the knee, and the molding has to be excellent on the gluteal side as well as on the trochanter. You can use a plaster of Paris or fiberglass plasters as Manish Dhawan has already demonstrated, or an hybrid, which again we use in India. As I said, mold under the gluteal fold and greater trochanter. A connecting bar may be needed if you are using only POP, but a hybrid cast is strong enough so that you don't need that bar. And in the end, trim and petal the cast so that there are no sharp edges and there is adequate space for breathing, umbilicus, as well as for motion and urine. So this is the application. I use a standard wooden board and place the baby at the edge of the board in the frame, or if you have a child spica frame, you can use that. The hip should be in about 70 to 90 degrees of flexion and about 40-degree abduction and external rotation. The safe zone should be assessed. The arthrogram having been done, confirmed your safe zone. If required, an adductor tenotomy has been done, and now you're doing the spica. So you could put a towel around the abdomen, cover the extremity with a stockinette, and a small 2-inch or 3-inch roll is started from the nipple downwards. So please remember, as compared to other casts, this is a high cast. It goes right up to the xiphisternum or the nipple area for adequate hold. And then you come down from there, apply felt over the bony prominences additionally, and you apply the plaster typically in two layers. One is from the nipple line to the knees, and then the distal portion below knee. A single 4-inch roll you can start with from the nipple to the back of the sacrum. Use small slabs to reinforce, and then round the inguinal region to the gluteal region, and always mold on the gluteal region. So this is an example. If you see the mold around the gluteal region here, that is very important, so that you are giving external rotation with ortolani maneuver and you are actually pushing the hip anteriorly into its socket so that it prevents it from popping out. So the molding is very important, the abduction is very important, making sure it's in human position is very important, so that and then you have a nice cutout for the perineal hygiene. So just to demonstrate, this is the arm board. The anesthetic is at the head end. We have taken the patient a little off the board, and you start rolling the Webril or your cast padding from the xiphisternum downwards. The surgeon typically stands in between the legs. Two people are holding the legs on either side, while this is after you have confirmed your reduction and done your arthrogram. This is just application of the cast in the human position. So again, starting from the thigh, going around the inguinal region, make sure there's adequate padding there. Additional felt padding may be required around bony prominences, so just go around that area nicely. After that, as I said, the gluteal molds, make sure that you are right up to the gluteal region. Otherwise, sometimes for other conditions, the spicas are given pretty low. So I start with a simple gypsona plaster and go around from the nipple area. We have come down from the xiphisternal area to the affected side. Once that is done, we move again from the abdominal xiphisternal area in figure of 8 manner to the opposite thigh. This you pad excessively so that you can turn the cotton later and smoothen out all the curves so that there is no indentation anywhere. Then you reinforce. How do you reinforce? You make small slabs. You put a small slab on the anterolateral aspect of the thigh so that it gives a nice mold and doesn't break there. The second trick that you can do is use the stick of your gypsona cast. So these are the anterolateral small slabs that I'm using to reinforce. And you can use another slab around the gluteal region on the affected side, because you need an extra sort of a stiffness there where your reduction is going to be. That's the left side here. The second thing I do is I put these sticks, which are the gypsona sticks, the plastic which is there, so that adds to
I think we have lost
stability, and it's easy to get it doesn't break. And finally, I use the fiber cast on top of that. As Dr. Manish said, once this dries off, Then you use your fiber cast around. Now, if you see, the plaster is going around the board that I am using. That is my spika board that we use. I have 2-3 sizes depending on the width of the pelvis, and I have smaller sizes which I use for my supracondylar fracture close reductions also. So once that fiber cast is applied, the next step is now removing the board. So this is the most important step. While removal of the board, the anesthetist has to support the head and the tube so that it does not invariably get pulled out. While you are holding the pelvic region, somebody will pull the board from the opposite side by a wriggling movement. Don't pull it straight, just do a wriggling movement and it comes off very nicely so that you can place the baby back on the table and hand it over to the anesthetist for extubation, and that shows that this has got an excellent spica with good adequate space all around. The gluteal mold has been done, and then final finishing we put dynaplast tapes which go inside and on the outside so that the sharp edges don't hurt the baby at any point in time. So that is how we finish it. So again, to reiterate, this is the human position, flexion of about 90, abduction less than 50. You can put straps like this. You can add clips, put straps around the shoulder so that the spica doesn't slide down in case you want to carry the baby around. All these things we have seen being done abroad. I haven't done them myself. We don't have these available to us. And as I always said earlier, confirm your reduction with a immediate X-ray where the arthrographic dye may persist and you can see it, or a single slice CT to see that your hip is reduced at the end of the cast. When do you change the cast? Typically at 4 to 6 weeks, again under anesthesia, you must examine the hip stability and recast for another 6 weeks. So typically 12 weeks of casting is needed. A third cast may or may not be needed, and post cast bracing is mandatory. Make sure that you are holding till the hip becomes stable and there is no dislocation so that the acetabulum remodels very well. What are the pitfalls? Inadequate reduction will lead to redislocation. Identify it early, position your hip better, mold it better, or then you will go for an open reduction. There are some cast problems in the family. If they don't take care, there can be soiling, pressure sores, breakages if you are not reinforced well. Late dislocation happens if there is inadequate reduction or a very narrow safe zone, or the acetabulum does not remodel and may still need open reduction after some time. AVN happens if you exceed abduction of 50 and internal rotation of over 15 degrees, typically in younger babies less than 6 months when the head is still soft, or multiple forceful attempts at reduction. A few clinical examples: the left side congenital hip dislocation, the left side after reduction, you can see the appearance of ossific nucleus within the next 3 months, which suggests that there is no AVN. This is another case where there is a left-sided hip dislocation, again reduced, that is in the spica, that is after reduction, the head located in the inferomedial quadrant after the lines are drawn. This is a right-sided hip dislocation, that is the arthrogram after reduction, and that is how the baby is comfortable in the spica. So I thank you very much for a patient hearing, and I'm happy to answer any questions if there are. And thank you again, Dr. Ravi and Dr. Manish and Dr. Gupta for accommodating me.
Dr. Sandeep, your video is not on.
Yeah, I'll just do that.
Yeah.
Yes.
Yeah, perfect.
Sorry.
So very nice presentation, as always, very precise and informative for the postgraduates. So any questions and comments from the faculty, please?
Yes, sir.
Dr. Sanjay?
Very nice
Yeah,
presentation,
Dr. Shah
Dr.
wants to say
Sandeep.
something.
Yeah, it's a very good presentation.
Thanks, Sanjay.
And the only observation was that the spica that you demonstrated was not in a human position.
No. The problem was, Sanjay, I actually today I did a post-septic hip dislocation, open reduction with a varus and extension osteotomy. And I did the spica today afternoon so that I could show you some video.
Also, it was a
This
different.
is not a classical. This is not
yeah.
a classical close reduction arthrogram spica.
Yeah, okay.
You saw the baby was slightly big, but I wanted to show you the steps.
Right. And do you, in these close reductions that you do for DDH, do you always put a POP underneath and then put fiber on
Yes,
top?
because as was pointed out, molding is very nice with POP. And you must customize the width of your cast by cutting your cast 6 inch into 3, or if you have availability of 3 inches in very small limbs when you are doing close reductions. Because what happens is that if the size of the cast is too big, everything becomes messy. It's very nice to have very precisely cut plaster and small slabs made, and you must prepare yourself like you're doing a TKR when you do a DDH casting. If you pay attention and be gentle, your complication rates are much lower.
Nice.
Dr. Sandeep, you use orthogram in all the patients you are in DDH?
Yes, sir. Yes, sir. It is mandatory. I am sure Sanjay will agree because we have seen it very often. The patients coming to us saying that they have undergone a close reduction. The surgeon says he felt a pop, but the hip was out because the head can glide on the rim and give you funny kinds of sensations and sounds, but it may not be a concentric reduction and it tends to slip out. And in fact, I have seen surgeons doing a Salter osteotomy with the hip still out unless the prerequisite of us for a Salter is having a concentric stable reduction. Adding a pelvic osteotomy doesn't confer stability. First, you must seat the hip correctly in the socket. And that can be only confirmed with arthrography or CT. CT becomes expensive. On table, you can always do an arthrogram and study it so that you know what's happening.
Great.
Any comments, Sanjay?
No, I totally agree. In fact, in my practice, I have stopped doing a CT because when you send for a single cut CT, they do a whole CT, conferring a lot of radiation on a baby. So what I do is I would do an arthrogram, do an AP view on table, and do a lateral view on table. So I know exactly where the hip
So
is.
we shoot an X-ray, like I said, even through plaster, the dye remains for some time. You will get an arthrogram X-ray.
It highlights it, and so it's more accurate than doing a.
But I would highly recommend that, sir. Everybody should do an arthrogram before the baby goes out to confirm reduction. You must document it.
Sandeep, I have one observation that
Yes,
the
sir.
hip is in plaster cast,
Yes,
and
sir.
you are doing arthrogram in routinely. So, do you keep any window that if there's any infection in future, you can see for that?
So the arthrography dye is a water-soluble dye which disappears in about 45 minutes. I haven't had the experience of having infection because of an arthrogram ever so far
Neither
in
have
20
I.
years.
Neither have I.
I don't think it's reported either.
Dr. Sanjay, when you are using the board, you apply the plaster over the board posteriorly.
Over the board. That gives me the space. I don't have to put an abdominal mop or anything. It's just a wooden board on which we place the baby so that the buttocks come at the edge, so that it's easy to remove the board and you have adequate space. You don't need any customized special spika tables for that.
Number one. Number two, when you are using board, what about the the proximal and how you are holding the head and the upper back?
So you saw that the board is long enough. It's about 4 feet in length.
Yes.
It's about an inch thick and about I would say 12 inches in width along the pelvis. So that the length of the board, the whole baby is on the board and the board is off the table.
Okay.
So at the anesthetist hand, when he's holding the baby's mask, he's putting his elbow on the table to prevent the seesaw movement from happening. So anesthetist has to control the board from sagging. And from your side, you hold and mold. And with the C-arm also, you get a translucent view when you do arthrography. So you finish your reduction, you do your arthrogram, confirm your position, do your tenotomy, and then, so everything is on that arm board or a wooden board.
Okay, very nice.
It's a little low cost, cheap technique.
Very nice, very nice.
Rajesh, can I ask a question, Sandeep?
Yes, sir. Please.
Sandeep, thank you. It was a wonderful lecture. And as usual, whenever I listen to you, there is something to learn every time. Sandeep, I have a small doubt exactly what Rajesh asked about the board.
Yes,
we
sir.
used to put a midline steel long rod.
Yes, sir.
And keep the child on anything above the level with either two plastic bags or something, some box, something like that. Why I said this because I agreed that you don't need a abdominal listing, but when you remove the board, won't your gluteal mold go off? I mean that Because that's where support is must, isn't it?
Yes, sir. Yes, sir. So, like I said, it's the plaster molding on the gluteal region is very important, but the width of the board is not very thick, sir. It's just an inch. So the only problem I've had with the board is if I don't do a hybrid cast and use a pure fiber cast spica, which I have done sometimes, it becomes too tight at the abdomen, and removing that board becomes very difficult because it hardens so much that pulling that board out sometimes can be a struggle, especially with a high cast across the xiphisternum above the umbilicus. The child gets stuck on that, and we have had to split the plaster and then remove the board. So it's better to use gypsona first and then reinforce it with a fiber cast. I haven't lost the gluteal mold so much, so sir. Your point is well taken that you might lose it, but an extra padding there and molding that nicely should do the trick. So the spica is actually a holding device. It's not a reduction device. You have to do the reduction earlier.
So last comments by Dr. Harshad.
Dr. Rajesh, not comments.
Yeah, yeah.
It was a good lecture, of course. But coming to our plaster technique story, what we have today for postgraduates, can you spell out a few of the complications that you have with this and how to prevent them?
Yes, so complication. The reduction is one part and giving the spica is second part. So I had divided the lecture in two parts. The reduction and documentation of reduction by orthography is a must, which should be stable and judge your safe zones and add the adductor tenotomy. The complications happen if your reduction is not adequate. Redislocation is the commonest complication. And at 6 weeks, when you change the cast, you must reassess. It's not that one cast will do the job in a closed reduction. After 6 weeks, when you take the child again, you may have to redo your reduction. If it is not stable, be prepared to warn the family that at walking age, you're going to do an open reduction. And the other cast problems are usually because of soil, soakage, and bed sores. If they don't turn the child 4 hourly, don't keep it dry. So typically what I've observed is a female baby, which is more common with DDH, they don't pass urine in a trajectory or a projectile fashion. Boys will urinate all over the cast because of the way they urinate. So I always tell them that you must put a nappy pad or a Huggies, but change it frequently. Keeping it soggy and soaked causes a lot of rash. So I tell them if it gets wet, what you do is use a hair dryer, which most of the families have at home. Blow dry it, make it dry, and put some talcum powder so that the perineal area remains dry, and turn the child frequently so that it doesn't get wet, and report back if there are any such complications. So taking care of the spica is a big job.
Yeah, one more question based on
Sir.
your this one. Some of the slides showed abduction, human position, abduction, flexion,
Yes,
abduction, and internal rotation. I thought it
external.
is external rotation.
Yeah.
You cannot internal rotate when you flex and abduct the limb. How do you do it?
No. When you flex abduct, you can internally rotate, but the problem is if you exceed. Sometimes, sir, what happens is that when derotation osteotomies are needed, it's because the hip becomes stable in internal rotation. If your internal rotation is excessive, you are likely to get avian. It should sit back in the ortolani maneuver. You shouldn't have to internally rotate. That's why they have given a limit of how much internal rotation is permissible, and they have said it's less than 15 degrees, not more than 15. Very often the position is external. Flexion of about 90 and about 45 abduction and about 30 to 45 external rotation.
That is what I had thought all the time. But
yes,
then the slide mentioned internal rotation.
No, internal, they are saying avoid internal rotation exceeding 50.
Okay.
Dr. Sandeep, there are two, I'm Dr. Manish, there are two very important basic questions which are asked to the postgraduate. One is the intern triangle and other is the cast syndrome. Okay, for the benefit of postgraduate, can you...
Dr. Manish, I am going to cover cast syndrome.
So thanks, Gupta sir, because I don't know answer to either.
Then in complications, I'm going to cover that.
Okay, and you will cover the intern triangle also?
Dr. Manish can answer that. Intern triangle, I don't know that.
Okay, so that will...
Thanks for saving me, Rajesh sir.
After your lecture, we will take this.
Okay.
Thank you, sir. Thank you. Thanks for the privilege.
Rajesh?
Okay. Yeah, sir.
Rajesh, can I interrupt for 2 minutes?
Yes, sir.
Rajesh, already we have gone more than 1.5 hours, and we have not even finished 3 lectures. You got a long list of this thing, and I am being helped by my son. I won't be able to share my slides and this thing. He has to go, and I am feeling very tired and exhausted. If you permit, I can give my lecture.
Sir, can Dr. Mukherjee finish it 2 minutes?
Okay, let him finish, then you can take my lecture. Thanks, sir. Okay, let Mukherjee finish it, then you can take my lecture.
Thank you, sir.
Right, thank you.
Thank you, sir.
ऑनलाइन चल रहा है.
Is it okay, Rajesh?
Yes, share the screen. Share it. Your screen is not visible yet.
Now?
Now it is visible. Okay, start.
Yeah. I just finish up the few which I left with. I think I was somewhere here, yeah?
Yes.
So remodeling, so recycling of minerals with calcium phosphate and the conversion of primary laminar bone and the secondary laminar bone, which may take 7 years, and the osteoclast with their cutting cone edges, reabsorption of the bone and from the outside, and according to the functional on the Wolff's law, and the osteoblast grown and lay in the lamellar bone. So there are the factors of affecting the remodeling: the proximity of the appendicular skeleton, the juxtaepiphyseal deformity, more bone deposition on the concave side, and bone reabsorption on the convex side. So any deformities near the epiphysis have more chance of remodeling. Presence of the deformities near the particular epiphysis, remodeling is more when present near proximal humerus than distal humerus. So the factors affecting the remodeling are fracture location, fracture near the metaphyseal remodeling faster, the age of the patient, and the pathology of the bones. And this is the great man, Julius Wolff's. So that was the Wolff's law that says if loading on the particular bone is increased, the bone will remodel itself over the time, become stronger. The adaptive changes happens at the internal architecture of the trabeculis. And we have seen the central lines in the neck of femur, and the woven bone, as you can see downwards, how it come from the laminar bone. So factors affecting the fracture repair method of the treatment, as we have discussed: absolutely stability, rigid fixation, low strain environment, the primary repair, and the fractures is faster in children than old. This is nearly twice the rate. And factors which inhibits is smoking. Smoking inhibits different pathway. Radiation inhibits the fracture healing. And there are the hormones which influence. Growth hormone has a positive effect, increases the callar formation. PTH, as we all know, is a positive effect on bone remodeling. Calcitonin, it's a plus minus. No one know actually what it does in bone healing. Cortisone, it decreases the callus formation. And thereafter, we have ultrasound in fracture healing. Low intensity ultrasound increases mechanical strength of the callus, and the mechanical energy is transmitted into the cell. We have electricity and magnetic fields. They are charged with the molecules in the bones in the cartilage, and the electric stimulation area as a variety of the cellular activities that stimulates bone healing. And there are the papers showing the effect of the intramedullary implant with static magnetic field on nailing of the potential bending of the rabbit, and that increases the formation of the bone healing. So the bone graft, just lastly, in few words, the bone grafts and the bone graft substitute, they are also needed in bone healing in special situations. So indication is skeletal defect after tumor resection, reconstruction of the bone defect after failed arthroplasty, reconstruction of the congenital bone defect. There is augmentation of the cavity of the bone, repair of the fresh fracture with the bone loss, treatment of the non-union and arthrodesis of the joint. It provides lattice work in growing host bone, which is osteoconductive, supply live osteogenic cell, which is osteogenic property, growth factors induces bone formation, which is osteoinductive. The types of the grafts are the cancellous, corticocancellous, and the corticocancellous graft, autograft. We have syngraft, we have allograft, we have genograft, and we have Senhartis graft. So the sites, as we know, iliac crest, proximal tibia, trochanteric region of the femur, distal condyle of the femur, olecranon process of the ulna, and the distal radius talus process. So sites of obtaining cortical bone in the autografts is the fibula and tibial proximal hub. And the grafts, allografts are fresh frozen, and the freeze-dried grafts, and the osteochondral allograft, and large composite grafts. And with this, I thank you. Sorry for interruption for my network. Please pardon me. Any question if you have, I'm there, or Dr. Taneja is waiting. Sir is ill.
Hello. Stop sharing, Dr. Amitabh.
Yeah.
Stop sharing, please.
Yeah, I did.
Okay. So any comments, sir? Faculty, please. Yeah, Professor Ray.
He has, Dr. Mukherjee, thank you very much for your nice talk. And only I want to know that, the bone setters and non-conventional method of fracture healing, the counter irritants, whatever they use, the herbal product or some form of jari-buti, that counter irritant probably has got some effect on fracture healing. There are a lot of papers on this aspect. Any comment from you?
Thank you, Madhunda. It's really, I'm lucky to have you on the board. In fact, there are 2-3 studies. One is going on in Odisha. If someone is there, there's Bhadrak, there is a big bone setters, so they do it. So the counter irritants.
Andhra Pradesh, in Andhra
Pradesh also.
Near Tirupati, there are
hospital. They have a big hospital. They put the crushed fish and they make the mold and they use this counter irritant. Someone said it's the electric field, the static electricity which comes from the counter irritant that stimulates. But there are 2 people I know who are working on this to see how this works. So if I get something back to it, I will personally get back to you and I will ask them to publish in IGO if something positive comes in. Thank you for giving me this opportunity in this podium. Thank you all.
And I have a big competitor in Bangalore also.
And trust me, some of the cases, they really unite well, which we think that we cannot fix it. Cannot do without doing a surgery. They just fix it up and that heals also.
Sir, is that because of crushed fish or?
No. That's not a crush. They said that this crushed fish and other things, they produces and static electricity and changes the static electric field around the fracture site, which stimulates the osteons to come from one end to another end.
Dr. Rajesh, can I ask one question?
Yeah, can please.
Yeah, okay. That was only a comment. If there is a fracture, sir, Dr. Mukherjee.
Yes, sir.
If there is a closed fracture and you do plating, if there is an open fracture and you do plating, how does the bone heal? This was a question I had asked the postgraduate. So
if there is a
I wish you could clarify that on them.
If there is a closed fracture,
you do an open reduction and fix it with plate. There is an open fracture, you do an open reduction and fix it with plate. How does the bone unite in both these situations?
Sir, to be very honest, if it is a closed fracture and if you are uniting in certain, it comes from the day of injury to the day of operation when you are
not that. That is different. A closed fracture has come to you, you have opened it and done a fixation with plate.
Right.
And an open fracture has come to you, you have debrided it and fixed it with plate.
Yes.
Your bone healing stages, how does the bone heal? Is what I'm asking.
Initially, if it is the closed fracture and if you are opening it up, it is going to be treated as a type 1 intermedullary fixation. That's the way. That's going to follow. There will be less callus, it will be intermembranous time. But if it is an open fracture, then it is not going to follow the path of the first one. It is not going to follow. Then it will follow the next path. Somewhere in between, they unite in the secondary callus formation. If you can see that callus is exorbitant callus. It's not like the primary callus formation. So that is the difference what I personally feel. I don't know, sir, if I could answer
no callus formation at all. Even after 6 months, 9 months, X-ray does not show callus formation.
Yes, I do agree. I do agree with you.
Formation is seen, still the bone has united.
Yes, I do agree.
This is the question that I ask them, because our primary hematoma and then primary cellular infiltration stages are bypassed.
Yes, I do agree with you, sir.
Direct primary bone healing or primary bone union.
Yes, and there is more chances of refracture.
Primary bone union take place.
No. Dr. Harshad, can you specifically tell the postgraduates what it is?
If a plate has been put, what is the kind of bone union that you get? How do you get bone union? We call it as primary bone union, like what you have said. The postgraduate has to answer this question.
Okay. We carry on with
Dr. Rajesh.
I
Dr. Rajesh, can I have a small question?
Yes.
An important question.
Okay.
I just want to ask Dr. Mukherjee, is there any difference between the bone healing and the lengthening when we have the regenerate?
Beg your pardon, sir. Okay, lengthening. The quality of the bone in case of lengthening and the quality of the bone which is united by the primary callus or secondary callus, there is difference. There is different in the way that the quality of the bone healing by the lengthening process, which is by this gradual destruction, that is weaker. So you in Elizarov, after docking or after total making of the consolidation of the bone, you can see there is much more incidence of refracture, because this Haversian system is not much dense, that all Haversian system are there where the woven bone has been formed in the system. So the woven bone is not there. So this is a weaker system. We need to protect. We have to protect an elongated bony piece which has been elongated and made and new, and rather than a bone which has been united by primary or by secondary intention in end to end.
Okay, well taken, sir. Thank you.
Thank you very much.
So I think I request Dr. Professor Taneja to carry on with his talk.
Thank you, sir.
Thank you, Rajesh. And at the outset, let me thank the Indian Orthopedic Association, Rajesh and Manish in particular, for asking me to be a part of this faculty. The subject that I'm going to talk to you is on a cast bracing, which is very dear to me. And the second part of my talk will be, as Rajesh ordered me, that I should talk about the technique of the PTB plaster also. So, this is going to be my agenda, which I am going to talk to you. And when we were students in 1966, when I joined orthopedic, that was the main teaching, that how a fracture will unite. That was the standard teaching of the hero and farmers. Way back in 1972, I always wondered that why we are all the time immobilizing joint above and joint below. So I just devised my own brace and started using the leucoplast and a patient with a radius ulnar fracture, giving a traction and counter-traction system, putting a cotton padding, correcting the angulation. And to my utter surprise, the fracture united very well. And patient had a good function of the elbow and good function of the wrist. This I did it in about 12 to 15 cases. And when I presented in one of my meetings, I was a junior most man at that time in the town, and I was scolded very badly with my senior. What the hell you are doing, Dr. Taneja? This is no way of treating the fracture. I stopped doing that. We have already talked about this thing, that what is the history and how people used to use different methods of treating. Now, this is a very important thing and a common sense to everybody, that if the immobilization was so very important, then how did the fracture unite in the animal? Look at this girl who has an above elbow plaster and is doing all flexion and extension. A child walking in a spika, coming and then you find the fracture has united. How does a fracture unite in the ribs where there is no plaster immobilization? Even in the fracture clavicle, it's just a figure of eight bandage. So that means it is not very essential to have a joint above and joint below. The two very important things, the rest versus motion. And you know, the very famous man, Lucas Championnet, talked about the action is life. And this is the gentleman from France who was contemporary to the Huon Thomas, and they had a very different views. So we talked about the stabilization and immobilization. What you really need in a fracture union is a stabilization. You don't have to have a rigid immobilization as we have been talking in all these lectures, and we have contradicted what the IO people had taught us. And we all know that to have a good callus, I like the lecture given by Mukherjee, that callus is so important. And the callus depends on directly proportional to the micromotion and the vascularity there. If you do not have a macromotion, you don't get good callus. Do not have a good vascularity, you won't get it. There is one of the best article I've read is by E.A. Nicol, who said the normal method of union in a cortical fracture is by circumferential callus. I would doubt the wisdom of any method of treatment which is achieved a primary bone union by deliberately suppressing the role of periosteum. The periosteum plays a very important role. And now, of course, we do not talk about the primary bone union. And you know that a famous saying by John Charnley that operative treat is much easier as compared to the conservative treatment. And you all know that the philosophy is basically that you have a hydrostatic pressure created by the muscles around it, and then there is a cast around the skin which gives a compression, and the fracture remains in its position. That's a simple this thing. In what are the patients where you can do a cast bracing? Ideal cases, fracture shaft of the humerus. If you read the book by the Sarmiento, on the very day one, he has his own orthoplast and easy fit thermoplastic material. He puts it onto the patient with a fracture humerus, fracture shaft of the tibia. Ideal for treating it by this thing, isolated fracture of the ulna and fracture femur in children can all be very well treated. All such patients, you can see that, can be very well treated by this thing. But you see, when you're working in a big hospital and patient crowd of 200 to 250 patients, they come in different types of problems. They have a compound fracture, they are polio patient, fracture disease, post orthoplasty, all joints are stiff, there's a bone gap in lower limb, and you have a put an internal fixation which is very badly done. You do not know what to do about this thing. And I found, like you see, these are my very one of the old cases. You can see how badly the internal fixation has been done, and you don't expect the internal fixation to do anything. And they go into a fracture disease very fast, and they go into the stiffness of the joint. Patient who has gotten a polio and who has been on a tricycle, and if you don't mobilize the limb early, they lose their power. And you have a patient who has got an infected joint and you do not know, so we put in a cast brace, make them start mobilizing, put a Malacot's catheter, start draining them. I'll show you some more cases onto that. And these are some of the examples which we have been using in different types of patients. Where you must not use it, if it is anesthetic limb, if it is a diabetic with peripheral neuropathy, if it is an isolated radius, it is a Montegia fracture dislocation, spastic, intraarticular fracture, and mentally retarded patient. This is very important. When do you apply a cast brace? The best time to apply a cast brace is when you have achieved an intrinsic stability. That means you have all the swelling has gone, fracture is in position, and it is about 2 weeks or 3 weeks have passed. Fragments have started becoming sticky. That is what we mean by the intrinsic stability. That is the time when you should be applying the brace. So how long you should be keeping a brace? At least 6 to 8 weeks time. That is the time which will give you an idea whether my fracture is uniting or not uniting. If your fracture, you think the progress is unsatisfactory, you can go and do the femoral bone grafting. There are different types of cast bracing, locally made, the cast brace from the Alimco, the cast brace imported from this thing, different companies, different thermoplastic material. is all available. And you can see that these are the different types of the braces that we have been using. The material that you know, the stockinette, the soft roll, the plaster bandages, the brace, that is what is there you are seeing there. It is a jig which is very commonly used in the knee bracing, and these are some of the you can see that the one between the middle one and the lower one, they have been the different types of the joints which we use it for our caliper, and we have made them into different type of horse bracing. This is one which you are seeing on the right side is imported from the state. The one you are seeing in the right side photograph, they are of the thermoplastic material available from the Alimco. So this is some of the thermoplastic material which is taken from the Sarmiento book. And so the PTB plaster, PTB thermoplastic material, the Sarmiento has been talking it way back in 1960. In 1973, we have been doing this cast bracing. In Jaipur 2000 conference, I had invited Sarmiento, that was my role model, and he demonstrated how a PTB plaster is done. And these are some of the results of the short leg cast as compared to the PTB plaster. You will find there's not much of the difference in different authors. You can get as good a union as possible. And what are the tips on the technique? You see, that when I was over enthusiastic about using the cast bracing, which I've been doing from 1972, I have been using it for the hip. You can see that I've been using it for the knee joint also. I've been using a thigh sleeve. You can see this thing. And gradually, you can see this, that how a thigh sleeve is applied. And gradually, the most I eventually gave up the hip bracing, which is absolutely of no good. Thigh sleeve is very good for children, but one of the best cast bracing is a knee cast brace, which you are seeing in the lower photograph. And this thing, that how it is. Now we have been also using this cast brace for the elbow. The only thing that you have to be very careful while placing your brace, because your axis of rotation is anterior, whereas the axis of rotation in the knee joint is posterior. And you can see that how this cast brace has been applied for fracture around the elbow joint. And this is what I call as a oligocondyle brace. Is a very good method of treating the isolated fracture of ulna. You know, isolated fracture of the ulna, if you try to put a plating or something, it has a tendency to go into non-union. Now, if you put it into oligocondyle brace, you'll find the 90 to 95% of the isolated fracture will unite without any problem. Now, any method that you do, there are always a lot of complications. So I have, you have a swelling, breaking of the braces, loosening, breaking of the plaster of Paris, delayed union, non-union, mass union, all I'll show you some of my complications. Like in this patient, it has become loose, and some patient it has broken, and some patient that it has totally broken again. And you can see this thing, the patient who are using very vigorously these braces, these all complications can take place. The plaster can become loose, it can come down. Some people can do and go and they do their own repair. And you can see that how this plaster has gone this thing. And this brace has come out, this plaster from here. He has put in a towel around this thing and holding it this thing. This person is holding the brace in his hand. So these all type of complications can take place. Sometimes you can apply a very tight plaster and you can see that these type of complication can take place, which is a part of the complication of the plaster technique. You can have the blisters, and you can see that how the plaster has become very loose and come down. So these are some of the very important complications. I can show you that this patient had a distinct fracture treated by the cast brace, but there has been an angulation. You can see this patient did not unite well, it went into a non-union. Now, in a series given by the Sarmiento, in about 5,000 cases, he said it is the 1% of non-union. So it is not a very big problem, which is in any method of treatment, you can get mal-union or non-union. So just I will show you, I have been doing cast basic from last now more than 40 years, and I have done more than 4,000 cases. The majority of my patients were the tibia fracture, humeral shaft fracture was the second most commonly treatment fracture. Radius and ulna were very few, but femur fractures were few cases that I treated it. And we found That tibial fracture, mostly they were by the PTP technique, united in about 12 to 14 weeks. Tibial fracture treated by calcium union was about 14 to 15 weeks, and tibial fracture angulation was in 10%. Tibial fracture angulation more than 10 degrees, the mean shortening was 8 to 9 millimeter, non-union about 2% of the cases. Now here are some of the cases that I'll show you that this patient who had an internal fixation not very good done, we put it into a cast plate, went into beautiful callus formation. There is another patient who had an isolated fracture, it went to beautiful the callus formation. Another patient who had an femur nailing, beautiful callus formation. Another patient of the isolated fracture, ulna segmental fracture, went into beautifully unite the fracture. And this patient who had a rush nailing done in ulna, very loose nail, put into olecraноpendylar brace, fracture went into unite. Now these are type of the patients where very bad fixation has been done. I'm talking of those time when the good fixation were not available. Of course, now things have much changed, and you can see that whenever I was not very happy with the fixation, I say what to do. So patient will not be able to afford the cost. I say let me put them into a cast plate. The fracture disease will be taken care of, and there will be a good callus formation. And you can see some of the patients and how beautiful the callus formation has been done. You can see the fracture lower end of the tibia looks like to be a tumor, but is nothing but an massive callus formation of these patients. These are the few of the examples of my patient where the fracture went on united very well. So you can see all these there patient would start bending on the day one. They were driving a scooter. They could lift heavy weight. They could walk. They could go to the market, and all these things. You can see that this patient, Mr. Ramchandar, had a very bad community compound fracture of the tibia and fibula. The limb was going to be amputated. We tried to save him, and not only the limb was saved, it's so beautifully the whole tibia has been molded. Patient was a taxi driver, went back to his work. This gentleman, I found them in the market. He was roaming around doing some shopping. So you can see this thing, lady with a hip fracture and with a brace, they could do every work. And this is some of the example. You can see that this gentleman was a radiographer technician. He had a compound fracture. We put it into a cast bracing, and that you can see the range of motion after the plaster, the cast brace was removed. These are some of the more patients where you can see that what a good movement they get it. No problem of any stiffness, no problem of any plaster disease. You can see that he was a journalist, Mr. Vijay. He went on to a fracture of the tibia, and his fracture has united very well. I have many doctors, their brothers, their relatives who did not want any surgery. I've treated them with cast bracing, and the fracture have gone on to unite. Now we all know that the economics in our country works very well. People are still not listening. Today you talk of an operation. No operation cost in a middle level nursing home less than 50, 60,000 rupees. And cost base will not cost you more than 5 to 8,000 rupees. Hell of a difference. So the advantage is that the early limb and a patient rehabilitation, early mobilization of the adjustment joint, minimal morbidity and disability, free from complication of operation, that's an infection, and reduced hospital stay, and very cost effective. I call it an ideal middle path regime. It is of great utility when in unusual circumstances. It acts as a psychological stabilizer and very easy to apply. With the minimum complication, excellent result, low cost, it's a very appropriate technology for our country, very easily available. In 2000 conference, when I was the president of IOA, and myself and Sarmiento were talking to each other, and what Sarmiento has said, that the Sarmiento method of casting bracing is a very effective method, treating the fracture in the developing countries and even in the developed countries, especially for the fracture of the shaft of the femur and fracture of the tibia. Look, this is the words have come from a Sarmiento, who was the president of American Academy also. And he has talked about that this method is extremely good method, even in the developed countries. This is a very big statement which he made it. These are, people say, sir, do you still use the cast spacing? I say, yes, I do a lot of cast spacing. This is October 2013, one patient. This is 2016. You can see the patient, how I apply this thing. This is a 2018 patient, and this is again 2018 patient. This is 2018 patient, and this is 2018 patient, and this is, and you can see this patient after the cast brace has been removed, and their movement can be seen. This is 2019 cases, and this is a patient with a fracture of the tibia, and you can see that in the cast brace, the ankle cast brace, he has been moving around, and fracture went on to unite. I would suggest my all postgraduate students that they must read this book, The Non-Surgical Treatment of Fracture, by my role model Augusto Sarmiento and Lauren Lata. So this is one aspect of my talk, and now I will come to you. Rajesh said I should talk to you a little bit about the PTB plaster technique. No, you see, if you want to do it, what are the patients who are indication for a PTB? The patient who have got a mid-shaft fracture are ideal patient for doing a plaster, a patellar tendon bearing plaster. So limb is ready for the PTB this thing, and you can see that you have applied the stockinette, and you have done the marking of the patella, the patellar tendon, the tibial tuberosity, and then you can see that. Then you, after you have put in the stockinette, you are sitting on the stool, and your thigh should give a support to your foot, and you just put the foot in slightly external rotation so that the foot is in complete axis with the tibia. After this thing has been done, then you can use a little stockinette, the soft roll, so as to you prevent the heel and you prevent the middle malleolus and the lateral malleolus. I don't use the soft roll throughout the length. I use it for protecting the lateral, the head of the fibula, for the protecting the nerve. And then once this has been done, and then I make two slabs, an anterior slab and also a posterior slab. Now, once my two slabs are there ready, then first thing I do when my position is well in this thing, your knee is in flexion, and this knee should be in flexion about 70 to 80 degrees. And then you first apply a plaster boot. As I'm applying, you apply a plaster boot. And once the plaster boot has been applied, you can see that. And then you, after this thing, you do a good molding around the hip. You do a good molding around the tendo-Achilles. Make sure, this is what I again and again say, that the best molding is done in plaster of Paris. Please, please, please don't use the all synthetic cast for doing a cast bracing where you want to do a molding. You can make it a hybrid. If you want to increase the strength of this thing, you can put a one bandage over it, like Sandeep said, and after my DDH plaster, I put that. It looks very beautiful, pink color. Okay. Now, after you have done that, then you go and apply the plaster up to the knee joint. Go this thing, and just do not make it very tight. And then you can see that you this thing. Now you have the fracture. So you apply the anterior slab, and you be very careful that your fracture reduction is not lost. If there's any angulation or anything, this is the time to correct it. Okay, once you have done this thing, then is a time for you to the molding at the patellar tendon, at the lower pole of the patella, over the tibial tuberosity, and just below the patella. That is the most important part of this thing. And when you are doing this molding, it should be done in about 40 degrees of knee flexion. That's a very, very important. Well, if you do this thing, then you will be able to get full flexion and full extension. Now, I'll show you that this type of beautiful molding has been done, and you feel very satisfied. Okay, and then what do? Then you have to do a trimming of this thing. So you do the anterior trimming and you do the posterior trimming. Now, when you are due to a posterior trimming, this is anterior trimming you are doing it. Then you go and do the posterior trimming. What should be the level of posterior trimming? The level of the posterior trimming is at the level of the tibial tuberosity or slightly little lower down, so that it doesn't hamper the movements of the knee joint. That's very, very important. And after this thing has been done, then you can. You can unfold the stockinette, and then you do the molding. First do the metatarsal arch molding, then you do the medial arch molding, and then you will find that, and you have a full extension, and you have the full flexion of this patient. Okay, so a good PTB cast is at the ankle 90 degree and slight external rotation, molding at the hip, well-fitting cast, good molding at the patellar tendon, posterior trimming is important, good molding at the posterior median elevation, full flexion and extension. Thank you. This is what I wanted to talk to you in brief about a very important technique in the plaster technique, which our boys should know it, and they should know to practice this thing. It's a very good method by which you can make your patient ambulatory and walk and prevent many complications. Thank you, Rajesh. Thank you.
Thank you, Dr. Taneja. Privileged to have your talk here in this forum. Yeah. So as always. So, sir, please stop sharing.
Okay.
Stop sharing, sir.
Stop sharing. Yeah. Okay, that's okay.
So yeah. So any comments or questions to Professor Taneja? Sir, Dr. Manish, any questions from postgraduates? Sir, when you are applying PTB, when to do reduction maneuver? After you apply the anterior slab or before that?
No. Once you have, you are not applying a PTB plaster on day one. You only do it after about 2 weeks or 3 weeks. During that period, you have already achieved the reduction and patient was in a plaster slab or your cast. After 2 weeks or 3 weeks, when your fracture is sticky, you go and apply this thing. Now you have applied the one roll of the plaster. Okay, that is not enough. Then you apply the anterior slab, and that is the time when you can really make sure that your fracture is well in position, and that is the time when you can correct any angulation or any rotation you can do. Okay.
In a sticky plaster, in a sticky, when the fracture is a bit sticky, you can do some molding.
Yeah.
Yeah, Dr. Harshad.
Yeah, the molding for femur.
Yeah, molding for femur is the most important. In the two places you do the molding. One is at the femoral triangle. So you have the quadrilateral socket, you make it by using the two hands and the two hands on the one on the lateral or the medial side. Otherwise, if you go to the Alimco has that the plastic molds, which you can put the plastic mold both anteroposterior and lateral-medial and put a bandage and leave it for some time, and beautiful quadrilateral socket is formed. That is a very, very important part of whenever you form the thigh sleeve you give. The other place where you must do a good molding is a supracondylar area. Because if you don't do a good molding at supracondylar area, there's a tendency for the plaster to slip down. So you do it and hold it there till there's a good setting of this plaster. When I tell you one thing, when I used to do a lot of thigh sleeve in my patient, and when we found that plaster was getting loose and it would fall down, then we used to make a hole in the plaster in anteriorly and posteriorly and put little bandage from this side to that side and on the other head, and so that the plaster will not fall. These are the small things that you learn by your own techniques. Yeah.
Thank you,
Dr. Gupta. Dr. Gupta, question two said, Professor Taneja said, but this cast bracing method also theoretically it.
Yes.
Sir, you are not audible.
Ray?
Not audible, sir. Your audio, video, both not audible.
Your
video is not there.
Okay.
Okay. Sir, I request you to stay on, please. Even you have finished your talk, because we are having some interesting cases later on.
Okay. Probably I will take your permission. I'm feeling very exhausted.
No, sir. You take some tea, have some rest, and then come back. Because we are having 3 more talks.
Well, I know that because I took your permission.
Because the cases, they are interesting and they need little bit of discussion.
You have got many eminent faculty.
No, sir. Please stay on.
I try.
Thank you very much, sir.
Thank you so much, Rajesh, for your cooperation.
Thank you.
Thank you so much.
Dr. Venkatesh, 5 minutes for you. Carry on. Share your screen. After that, I'm going to have my talk now. I am waiting now. Okay.
Thank you, Rajesh.
Yeah.
I'll just take 5 minutes. At the
Yeah.
outset, I'd like to thank the organizers for giving me this opportunity to present my talk on functional position of joints. So, cast treatment can serve both as a non-surgical treatment option and as a means for providing post-operative protection of the limb. However, with the duration of immobilization intervals, the benefits of cast treatment are at risk. In order to minimize potential complications associated with cast like joint stiffness and contractures, immobilization of joints in functional position is very important. So what is functional position? Functional position is the one that least interferes with the important activities of daily life. Here, the antagonist muscles groups are balanced with less deforming force across the fracture and the joint. Immobilization of the joint in the functional position benefits functional recovery. So to get a good functional outcome, the functional position of the joints is very important. So we have to immobilize the extremities in functional position. So coming to joint positioning in upper limbs. So the optimal shoulder position in cast is 80 degrees of flexion, 40 degrees of abduction, 20 degrees of external rotation, and 20 degrees elevation of the forearm. This is the optimal position for the shoulder immobilization. For shoulder spika, we should keep this in flexion, 80 degrees of flexion, 40 degrees of abduction, 20 degrees of external rotation, and 20 degrees of elevation of the forearm. Coming to elbow position, so elbow is usually, now we keep it 90 degrees of flexion, both right and left. So whereas in kept at 20 to 30 degrees, but for immobilization in plaster, 90 degrees of flexion both for right and left. Coming to position of the proximal distal radial nerve joints, it is 10 degrees of pronation. So the optimal position for forearm immobilization, that is forearm fractures. So because of the deforming muscle forces, the level of the fracture determines the forearm rotation of the immobilization. For example, if there is a proximal third fractures, the supinator muscles will be acting. So to nullify the supinator muscle action, so we have to keep the limb in supination. Whereas for distal third fractures, because of the pronatory cortices, we got to keep in pronation. Whereas mid third fractures, it is neutral. So placing the forearm in extreme of supination or pronation should be avoided for any location of fractures in the forearm. Coming to wrist position, wrist is usually in the dorsal 20 to 30 degrees of dorsiflexion with full fist when full fist closure is possible. That is, it is dorsiflexion of 20 to 30 degrees wrist. Coming to position of the fingers and hand, for thumb position, slight flexion of 15 to 20 degrees in the metacarpophalangeal joint and 10 degrees in the interphalangeal joints. It should be opposed to the fingers rather than in the same plane with the other fingers. So this thing should be in the thumb should oppose all other 4 fingers of the hand. Coming to position of the fingers of 2nd to 5th fingers, functional position of metacarpophalangeal, that is MCP joint, is 45 to 50 degrees of flexion with interphalangeal joints 20 to 30 degrees of flexion. The fingers are positioned as if they are holding a bottle. Coming to joint positioning of the lower limbs, the functional position of the hip joint is 15 degrees of flexion, neutral abduction, and approximately 30 degrees of external rotation. Coming to knee position, the functional position of the knee in the cast is 10 to 20 degrees of flexion. But whereas whenever we put a walking cast, in weight bearing cast, the knee flexion should be less, that is should be around 10 degrees in order to achieve a better walking function. Otherwise, it should be 10 to 20 degrees of flexion.
Venkatesh, you are not audible. Hello. Venkatesh, you are not audible. Your video, audio gone.
Sir, please, if you are using microphone, just please remove your microphone actually. Rajesh sir, can I stop sharing for a while?
Yeah. Stop sharing for a while.
Sir, now just try again.
Venkatesh? Hello?
Venkatesh, sir, are you there?
Can I call him?
Sir, actually, he is not.
Any idea how many more slides left, Rajesh?
I think 2-3 slides more, sir.
Then probably we can go to the next
it's
talk.
concluding slide, sir.
Then probably can go for the next talk.
Yeah, I'll definitely go for the next talk. Will not wait.
Like later, he can add probably.
Yeah, I think phone is not also no.
This may be a power failure.
Okay.
He logged out, sir. Yeah, he's coming again. I am admitting him.
Okay.
Okay.
Yeah, he's in. He has rejoined, sir.
Okay.
But
yeah, he's come back.
He's already, yeah.
Yes, sir. Can you, am I audible?
Hear it again, sir.
Yeah, you're audible. Share the screen.
That is almost time. So this is the ankle position. So in standing position, all the joints are in the functional position. Thank you. Thank you.
Okay. Any comments are to Venkatesh because he has to leave for an emergency?
I think in the interest of time, we should all move on.
Okay, fine, sir.
So, yeah.
So thank you, Venkatesh. So I'll share my screen now.
Thank you, Rajesh.
Yeah. Thank you very much. We are almost in time because few very important talks are so. Okay, is my slide visible?
Yes, we can.
Yes, sir. Please go ahead, sir.
Yes.
Just put it on slide mode and go ahead, sir.
Yeah. So the very basic talk for the postgraduates, principles of plaster application. So plaster application, as we all know, is a technical skill which can be mastered with practice, As we require something, some practice, you sharpen our surgical skills. So is the case with the plaster application. The more we apply, the more we learn. And to apply a plaster properly, we should have the knowledge of its basic principles. And if these basic principles are not followed, then we land up in risks and complications. Before applying any plaster cast, we must assess the extremity for the displacement of the fractures, for any abrasions, any wounds, and any neurovascular status, distal neurovascular status of the extremity. And if a need is felt to have a plaster, we must decide whether the patient needs a splint or a cast. Now, as we know, cast and splints, they serve to immobilize the orthopedic injuries. And they are indicated in the treatment of the fractures, sprains, strains, ligament, injuries, tendon lacerations, and some inflammatory conditions. Now, there are stages of plaster application. What is the first stage? First stage involves the application of POP slab or the cast. The second stage is a setting stage. Here, there is a change of POP to gypsum, and it is defined as the time taken to form rigid dressing after contact with water. Third stage or green stage is a just set wet cast, and the fourth stage is also known as cast drying. Here, the cast dries. Here, excess of water is evaporated, and this results in a mature cast with multiple air pockets through which the skin breathes. Now, there are many factors which influence the plastering: temperature, strength, padding, incorporation, absorption, and time. So we are going to discuss one by one. Now, when we immerse the bandage in a cold water, the initial set is delayed. Thereby, the working length is increased. So we get more time to manipulate the fracture fragments when we are doing the reduction. Actually, we can feel the fragments within the cast. So that is why we need the fracture, we need the plaster which has a delayed set. Now, if we put the plaster bandage in a warm water, there will be a rapid set. Now, strength of the cast, the interlocking of the crystal formed is essential to the strength and the rigidity of the cast. The interlocking of the crystal, also known as the critical setting period, begins when the plaster reaches the thick creamy stage, becomes a thick rubbery, and starts losing its wet shiny appearance. So motion during the critical setting period interferes with this interlocking process and reduces the ultimate strength by as much as 77%. So the important thing is, while we are applying a plaster cast, we should ask the patient or our assistant not to mobilize the limb. We have to keep it in a static position. If we keep on moving the extremity, then the plaster will take a longer time to set, and then we have to apply few more bandages and the plaster will become heavy. Now the cast drying occurs by evaporation of the water. The evaporation from the cast surface is influenced by air temperature, humidity, and circulation about the cast. The thick casts take longer to dry than the thinner ones, and the strength increases as drying occurs. The third is padding. Padding is important as it protects the skin and the soft tissues during the cast removal and also prevents the skin from the thermal injury. The poor padding will lead to sores and the over padding lead to loose casts. So padding has to be optimum. Now incorporation, what is the meaning of this? The plaster of Paris in a wet stage is infinitely moldable, and it can be set around like cast brace, hinges, and walking heels. But when to apply? When we have to apply these appliances, we apply first few layers of the plaster bandage, and when it sets bit, and then we apply these braces with a fresh bandage of plaster POP. Why? Because if we apply these appliances on a wet cast, they are going to indent the plaster and indent the underlying skin, leading to the pressure source. Now, excess exudates from inside or moisture from outside will weaken the cast and the cast will break. So time, the strength of the POP builds up over a period of time. It usually takes 48 to 72 hours for a fracture to be completely dry, and we should not allow the patient to wait before that. Now, this is the material we used for applying a plaster cast. We are going to discuss them one by one. Now, coming to stockinette, for the finger it is around 1 inch. For the upper extremity it is 2 to 3 inches. For the lower extremity it is 3 to 4 inches. Now, padding or the cotton for the hand and foot it is 2 inches. For the upper extremity 2 to 3 inches. For the lower extremity 4 to 6 inches. Casting material or plaster of Paris, hand and foot it is 2 to 3 inches, upper extremity 3 to 4 inches, and lower extremity we use 4 to 6 inches. Now synthetic bandage, again hand and foot 2 to 3 inches, upper extremity 3 to 4, and lower extremity 4 to 5. There is no 6 inches bandage in a synthetic cast. Now coming to pattern of application, what is slab? It is POP which encloses the partial circumference of the limb. What is a cast? Here POP encloses the full circumference of the limb. What is spica? It includes trunk and or one or more limbs. So it is spica. What is brace? Which is a splintage which can allow motion at the adjacent joints. Now coming to interposition material. The plaster can be applied unpadded. Here there is no material interposed between POP and the skin. It was practiced by Bohler. As Sir Charley also recommended its use in the treatment of Colles fracture, scaphoid, and Bennett fracture. The plea given by them was it rigidly fixes the fracture, but the downside is it is difficult to remove and it does not compensate for the swelling. So the current practice is to use a padded cast. Here interposed material is used and it may be stockinette and wool or wool alone. Now we are going to discuss one by one what is slab. It is a temporary splint used in the initial stages of fracture treatment, in first aid, in the post-operative period, and in infections to give rest to the part. It is made up of half by POP and half by bandage roll, and hence can accommodate the swelling in the initial stages of fracture. It is prepared according to the required length. Now, there are three methods of applying slab. One is a dry method. Here, the slab is prepared first and then dipped in water. Okay, this is the commonly employed method. Wet method is, here the slab is prepared after dipping the POP in water, and this is rare and it requires some experience. Pattern method, here the slabs are fashioned in the desired way before dipping it in water. It means we cut it to the proper shape and then dip. Now, splinting is done in many ways. It can be accomplished in many ways. The first one is how to apply a proper slab. So this is a video to show how we apply a proper slab. Okay, so we are going to mark the extent of the slab. Okay.
Video is not running.
No, I'll speak out. I'll speak out. Then I apply a, am audible?
You are audible, but video is not running.
No problem. No, video is running, sir. Sound is not there.
The video picture is not coming.
Video picture is not coming.
Not coming.
Video is not running. Wait.
We try.
We could not see the video.
Just wait.
Rajesh?
Sir, I'm just wait.
Yeah.
Is visible now?
Yeah, it's coming now.
Yes, it is now visible.
Fine. So we mark the extent of the slab. Okay. Then we apply some powder to make it smooth. Now we take a appropriate size stockinette and roll it over. The important thing is here is it should extend 8 to 10 centimeter beyond the marked level. Okay. And second important thing here is there should not be any wrinkles in the stockinette, no bunching. Otherwise, it will lead to the pressure source. So these two things are very, very important. Now we take appropriate size padding, and the important thing here is we should go from distal to proximal. Distal to proximal, it is important. Okay.
Yes.
Second thing important is we should roll it very smoothly. Again, there should not be any bunching here. It should not be applied in ugly lumps, and it should cover the 50% of the preceding layer. Thereby, it gives us 2 layers of the cotton, right? So see here, it is going very smooth. And third important point here is we should go 2 to 3 centimeter beyond the marked level. Stockinette is 8 to 10 and cotton is 2 to 3 centimeters beyond the marked level. Now, another important thing is at the edges of the plaster cast or a slab, we should apply some extra padding to prevent rubbing of the plaster, sharp edges of the plaster. And we should also apply it on the bony prominences like here on the ulnar head. So some extra padding has to be applied at the bony prominences and at the ends of the plaster or a slab. Now we take a already made slab, and for the upper extremity it is 6 to 10 layers, and for the lower extremity it is 12 to 15 layers. Wet it, apply it to the extremity, and mold it to the contours of the extremity. Mold it to the contours of the extremity like this. Okay, so mold it properly. Then we take a wet cotton bandage and then again apply it from the distal to the proximal. Okay, distal to the proximal. So here also, now the important thing here is when we have done this, we hold the position of the extremity, whatever the position you want, for a few minutes to let it set a bit. Otherwise, if you keep on moving, the plaster cast will break. Okay, here I have applied ulnar gutter. Now what I am doing here is I am everting the edges of the cotton and the stockinette, so it gives a smooth edges so that it does not break. It does not rub against the skin and there are no pressure source. And lastly, I apply the stocking, the another bandage over this to give it a smooth surface. So that is how a plaster slab is applied. A, presentation. Okay. So the second way to create a splint is without the use of stockinette or the circumferential padding. Here, several layers of the padding that are slightly wider and longer than the splint are applied directly to the smooth and wet splint. So here there is no padding inside. The only padding is this one, and this is slightly wider than the plaster layer, and it is held in place with a cotton bandage. There are also pre-packaged splints available in the market, which consist of fiberglass and padding wrapped in a mesh layers, and we can cut it easily and mold it to the extremity. Now, there are also prefabricated splints available, but they are less custom fit and they may be limited by cost and availability. Now, coming to cast, here the POP completely encircles the limb. It is used as a definitive form of fracture treatment and also to correct the deformities. Now, there are three methods of applying POP cast. One is a skin tight cast. It is same as the unpadded cast. Third is a bologna. Second is a bologna cast. Here, generous amount of cotton padding is applied to the limb before putting the cast. This is a commonly employed method by most of us. And third is a three-tier cast. Here, the stockinette used first, over which the cotton padding is applied before applying the POP. What is spika? Spika encircles a part of the body in figure of 8 fashion. Here, example is a hip spika for fracture around the hip and fracture shaft of the femur. What is functional cast brace? We already had a talk on this. So it provides immobilization, but also promotes early activity and early joint motion. Now, splinting versus casting. When considering whether to apply a splint or a cast, the physician must assess the stage and the severity of the injury, the potential for instability, the risk of complications, and the patient's functional requirements. The splint use offer many advantages over casting. Splints are faster and easy to apply, maybe static or dynamic. Splints, being non-circumferential, allows for natural swelling that occurs during the initial inflammatory phase of the injury. It is a preferred method of immobilization in the acute care setting, and splints may be removed more easily than the cast, allowing for the regular inspection of the injury site. But the disadvantages are there is a lack of patient compliance and excessive motion at the injury site. Splints are inappropriate for definitive care of unstable or potentially unstable type of injuries. So casting is the mainstay of treatment for most of the fractures, and it provides more effective immobilization, but it requires more skill and time to apply, and they have a high risk of complications if not applied properly. Now, there is an alternative POP. We have already discussed it, fiberglass fabric impregnated with polyurethane resin, but the plaster has traditionally been the preferred material for splints and casts. Plaster is more pliable and has a lower setting time than fiberglass. So, important thing is, what are the rules guiding POP use for the postgraduates? The surgeon should examine the limb and the fracture site, documenting any skin lesions and the neurovascular status. Very important. The radiograph should be reviewed thoroughly to determine the fracture pattern. The motion required to adequately reduce the fracture should be rehearsed ahead of the commencement of procedure. POP should be applied by the surgeon and not by the assistant or the plaster room boys. Plaster procedure requires at least one assistant. Plaster should be snugly fitting and should not be too tight or too loose. And uniform thickness of the plaster is preferred. It is not that at one place you apply one layer and other place you apply 10 layers. It has to be uniform thickness. Otherwise, there are stress risers and the plaster will break. It should be molded with the palm and not with the fingers for the fear of indentation. Very important. When you are molding, mold it with your palms. So immobilize one joint below and one above the reduced fracture, but there are few exceptions, but this is the general rule. The joint should be immobilized in the functional position as already told by Dr. Venkatesh. Very important is to check the neurovascular status after plaster application. Very, very important. And do check X-ray for acceptability of the reduction. Now, I am going to demonstrate a scaphoid cast for the students, how to apply a scaphoid cast. Can you see my video, sir?
Yes, it is visible.
Okay, so again we mark the extent of the plaster cast. Same way, apply some powder, apply an appropriate side stockinette. Same way, 8 to 10 centimeter beyond the marked level, no bunching, nothing. It has to be very, very smooth so as to prevent the pressure source. Apply cotton from distal to proximal, very, very smooth. Same rule, 2 to 3 centimeter above and below the marking level, and it should cover 50% of the preceding layer. Protect the extra. Hello. There is some background noise, please. Hello, please. So there is some background noise, please.
Can everybody mute, please?
Everybody mute, please. Please. Request. Hello.
Ravi, mute everyone.
Please mute everyone. Please mute. Okay. Thank you. So we apply some extra cotton as already told you at the edges and at the pressure points. Now here I am applying a scaphoid cast. So position in the scaphoid cast is very important. Now it is a cup holding position. We know we take a bandage, appropriate size bandage, wet it in water, let the bubbles come out, and then we take out the bandage, hold it properly, and again we go from distal to proximal like this. We take IP joint of the thumb here in the cast. Okay, important thing here is we should not apply it. It should not be applied too tight and too loose. And we should hold the plaster bandage in the center with the fingertips. See how I am going here. I am, and with other hand is molding it. See here. Other hand is molding it. Okay. When I apply one layer, I mold it, and I mold it with my palm and not by the finger. Mold it with the palm. Why to mold after every plaster bandage is there is an interlocking of the plaster, and there are no air pockets inside. If the air pockets remain inside, then that is a stress riser and the pressure and the fracture will break. We take another plaster, again same thing, it goes from this. An important thing what I am demonstrated here is don't apply many layers at one place like this. Don't apply many layers at one place. It has to be very smooth from distal to proximal in a uniform way. Okay. Then we hold the position. I have already told that it has to be whatever position you want. Hold it for few minutes to let it set. Okay. And then again I invert the edges. Then I apply the final bandage. So this is it. I apply a proper plaster cast. So I move on with my next slide. Now very important things are, what is wedging of the plaster cast? I think most of the postgraduates are not knowing or not doing this. What is wedging? So in a fresh fracture, when there is an unacceptable loss of reduction and cast is well fitting, we can do the wedging. So at the apex of the deformity, we cut the plaster to 2/3 of the circumference, 2/3 of the circumference. We open the wedge and wedge is kept open with a wooden piece or a car screw, okay, after the correction. And then we repair it with a fresh layer of the plaster. Now here, both bone fracture is corrected with a wedging. See here, the beautiful reduction here. Here, again, fracture both bone distal leg, corrected with the wedging. See here, alignment here. So wedging is very important and should be known to each postgraduates. Second important concept is cast index. What is cast index? It is a ratio of the sagittal to coronal weight from inside of the cast, inside edges of the cast. So this is the lateral view, this is the AP view. So A/V is the cast index. Now, the cross section of an appropriate forearm plaster should resemble an oval and not a circle. So for optimum cast fitting in the distal forearm fracture treated, the sagittal to coronal ratio should be 0.7. It is different for different parts. Okay, for the leg it is 1.3, and for the arm it is 1.2. So it is not same for everywhere. So well-fitting plasters are important with any immobilized limb. See here, example of forearm, it should resemble an oval. If it is round, it means it is not properly molded. So the reduction will fail. So this is cast index. Another concept is 3-point fixation. Again, very, very important. Now, 3-point contact and stabilization is necessary to maintain most of the closed reductions. So every bone has a compressible surface and a tensile surface. So when there is a bending force to break a fracture, the soft tissue on the convex side breaks, and there is a bridge of the soft tissue on the concave surface. So when we reduce it and held the reduction with these 3 points, so this is 1, this is 2nd, and this is 3rd. So soft tissue bridge comes under tension, and if any of the force is removed, there is a loss of reduction. So this is 3-point fixation. Now it again here, see here, this is maintained here, this bridge of the soft tissue is maintained here, and when we do the reduction, first force, second force, third force, there is a beautiful reduction here. Okay, this is a 3-point fixation in the cast. We maintain the cast in this position. So it produces tension in the intact soft tissues. It produces compression across the fracture site to immobilize the fracture, and it is needed for the fractures which are unstable. So a straight cast will usually contain a crooked bone, but a curved cast will generally contain a well-aligned bone. So this is how it looks like. See here, hinges here. When we do the reduction, 1 point, 2nd point, 2nd point, and the 3rd point, 1, 2, and 3. It can be like that only, but it is 3-point fixation. And if it is done properly, there are less chances of loss of reduction. So what is aftercare? Very important again. Counsel the patients on signs of neurovascular compromise. Reinforce all the cracks and weak areas with more POP locally. Limb elevation has to be done. Check if the POP is restricting movement. Ensure all the joints not immobilize the cast has a full range of motion. Keep POP dry. Any area of localized pain should be windowed, and it may be a developing pressure sore. The patient should be reviewed in 1 to 2 weeks and x-rays done to reaffirm maintenance of reduction. So there are common casting errors and poor choice of cast, redundancy and bunching of the cast liners, excess tight piping and cast material, inadequate padding, failure to extend the cast properly, poor molding, and acceptance of a suboptimal cast. So in conclusion, despite revolutionary advances in management of injury, especially those of musculoskeletal system, POP still remains very useful in carefully selected cases, obviating the need for unnecessary surgery with its attendant risks. Thank you. Okay, so any questions, sir? Any comments?
Yeah, doctor. Can I come in, sir? Doctor,
Yeah, please come in now.
Dr. Rajesh Gupta, I just wanting to know about the wedging. How safe it is to do wedging in a synthetic cast, or means which is safer? Is it safe like we do it in POP? Sometimes
See, it is very important question. It is in plaster of Paris, wedging is a little bit less risky because we are applying few more layers of the plaster cast, and in a synthetic cast we are applying 1 and 2 layers, and when we keep a wedge there are more chances of irritation of the skin or pressure sores. So we must advise the wedging in a synthetic cast.
Okay. Now just a comment, because it has come previously that regarding the interns triangle, because sometimes it is asked.
See, to be very frank, I don't know what is intern triangle. If you can throw a light on this.
Interns triangle is actually a weak part when you apply hip spica. It is between the posteriorly between the junction of torso and the leg. So why the name intern triangle is given? Because if you are not very experienced in applying the spica, the cast usually breaks at that point. So it is important to reinforce it down at the posterior side, between the junction of, you have to put extra slabs, and also it is important to reinforce the spica cast entirely around the hip joint crease, which is not an interns triangle. Interns triangle is always posteriorly. So that is just a comment.
Okay, fine, thank you. Any other comments? Dr. Manish, there are no questions from the audience or postgraduates?
Not still, sir. Once I receive, I'll let you know.
Okay, no problem.
How many have registered audience to this?
I'll let you know. Just
so if there is no question, we carry on with our next talk.
Yeah.
Yeah, Dr. Atul Bahadur, please. Dr. Atul, are you on?
I'm coming in.
Yeah, please.
I'm sharing my slides.
Yeah.
Hello.
Hi, hello, sir.
Can you hear me?
Yeah, sir. Yeah.
Oh,
we can hear you, but the slide has not come.
Okay. The slide shows. Are the slide visible?
No, sir.
No,
not yet.
Not yet, sir. Not yet.
Okay. Now they're visible?
No, sir.
No.
Not yet.
So just please unshare it and then share it again, sir.
Okay, I'll do that. Stop share. And then share.
Share it again, sir.
Okay, I come here. Are the slides visible now?
Not yet, but
not yet, sir.
I'll do it again then.
Yeah, it's coming.
Yeah, okay.
Okay. Then
full screen, sir. Full screen, sir.
I've already this thing.
Full screen, sir.
I've done F5. It'll just come, I think.
Actually, your system is hanging. Actually, so to some extent.
Actually, there's a problem with the internet connection. Also, we are having out here right now.
Yeah, sir.
So that may be this thing. Anyway, I'll start. Most of the plasters that we have already discussed and seen about. Plasters is a it's not coming. I'll just try the other this thing then. Yeah. Now the full screen is there. The slide is visible?
No, not yet. Not yet. Actually, there is a lag between sharing and just.
Okay. Now the slides are visible?
Not yet, sir.
Now?
Not yet.
Can we? Sir, can we move ahead with the next talk?
Atul, sir.
Cut out the things.
Atul, sir.
Yeah, I'll just do it. I'll do it. Okay. I'll stop share.
Atul, sir, can you mail me? Can you mail the PPT to me?
Yeah, I'll do it. I'll do it.
Just, I will try to run it from my side also.
Yeah.
Okay, I'll just do it.
Sir, can we move on with the next talk?
Sure, sure.
Dr. Sanjay? Dr. Sanjay, are you here?
Yes, very much.
Can you share, sir?
Okay. So is that okay?
Yeah, okay, sir.
Yes, sir.
Okay, I'll quickly run through this Ponseti casting technique in clubfoot, being mindful of the time and the late hour that we have right now. So this is Ponseti casting technique in the clubfoot. My name is Sanjay Saroop. I'm a pediatric orthopedic surgeon out of Delhi, NCR, and I'm currently the chairman of pediatric orthopedic division at Artemis Hospital. So as you know, the deformity in clubfoot, we all know it. The hindfoot is in equinus and varus. The midfoot has a cavus. The forefoot has adduction, varus, and supination. But it appears to be, it is apparently in supination, but it is actually pronated on the hindfoot. And the ankle and subtalar joints are usually in an equinus. There is posterior displacement of the lateral malleolus. The heel is in varus. And the talus is usually in an equinus and in medial rotation. Medial angulation to the talar head, and calcaneum is in equinus, varus, and supination. So these are the standard deformities that we see in a clubfoot. Now, the midfoot is a rigid deformity. The navicular is usually displaced medially. In this X-ray, it is not ossified, so you can't see it. Cuboid is also displaced medially. There is a curved and a long lateral border, and there are soft tissue contractures, and most importantly, there is a muscle imbalance, which we don't much talk about. Now, what are the principles of casting? When I was a medical student, we grew up on the kite method, which was originally described in 1924. And averagely, if you look at world literature, it takes about 36 casts for correction, with a success of 15 to 50%. Ponseti method was initially invented in 1948. We came to know of it in the 1990s, and it was like a breath of fresh air. He emphasized on forefoot cavus correction. Calcaneum corrects with the forefoot abduction. You don't have to correct the calcaneum deformity. Then at the end of the serial casting, you have to do a percutaneous tenotomy, and you have to stretch the contracted tissues by manipulation, which was never known before that period of time. So it was a big revolution. I'll just go through this thing. It starts usually by the 5th day of life. You have to counsel the parents. You have to examine and document. You have to classify first. As per the Ponseti grade, you have to take a clinical photograph. In older children, you might need pedicloral, and you have to wait 1 hour before casting when you've given pedicloral so that the baby can fall asleep. Now, what you need is a casting room has to be quiet. You need 2 and 3 inch POP rolls and a 4 inch soft cast padding. And you need a 1 inch tape. You need warm water, which should be at bath temperature. And you need a 90-degree hemostat, and you need white vinegar. Usually we use white vinegar to remove the plaster, and that is taught to the parents. You add 1 cup of white vinegar into a basin full of warm water and drip the water over the plaster. It becomes soft very quickly and can be removed like a bandage. We'd never use cutters with babies because cutters make an awful lot of noise and they can frighten the hell out of the kid, and sometimes it can cause burns also. So a calm and quiet child is essential to the success of the technique. We always use a soother, so the baby is quiet and we can apply the plaster, as you can see here. So the first ray is always in flexion. As you can see, the navicular lies inferior to the head of the talus and it lies medial to it. So the first correction is always of the first ray. You have to bring it back into a correct alignment. How do we do that? You extend the first metatarsal and supinate the foot further. So that is the first and the most important maneuver, and it is the key to the whole technique. So this is what you do. You supinate the forefoot, and there you are. You can see the same picture from below. You supinate the forefoot, you lift the first ray up and supinate the forefoot so that you bring into alignment the first ray, the medial cuneiform, the navicular, and the talar head. Right? And the cast is also applied in supination. So it eliminates first ray pronation, it resolves the cavus, and the first ray is reduced. After this, the second maneuver, once you have a supinated forefoot, you start gently abducting it. So what you do is you put your thumb onto the head of the talus. Now, where is the head of the talus? It is the lateral most bony protrusion in front of the lateral malleolus. You never touch the heel. Your index finger usually rests on the medial malleolus. And this is what you do. You abduct. And you abduct even more. You can see in the diagram, the thumb is pushing the talar head and the rest of the foot is being abducted on a supinated foot. And you never touch the talus. As you do this movement, the calcaneum gradually derotates and everts. And it comes into good alignment. And also that eversion causes a relaxation of the tendoachilles, and therefore the equinus also starts resolving. As you get more and more resolution of the equinus, you push the foot up more and more, not forcibly, but only as much as the slack will allow. And remember, the index and the middle finger are on the medial malleolus, thumb is on the talar head, and you abduct the supinated foot with the other. That's the way you reduce it, and you apply a plaster. And complete correction usually requires a severe abduction. That means you take it well beyond the point of what is considered normal alignment of the foot. In our technique, we have been using this technique for many, many years now. We have been using it since, I think, 2004. We use a thumb in cast technique. That means we hold the alignment and somebody casts over. The thumb is inside the foot, as you can see in the cast, and it keeps a steady pressure while the whole plaster is wrapped around and while you mold the plaster around the heel. And then you you lift up elevate the edges of the hole with a hemostat, because these edges usually can cause a pressure sore. You put a cotton pad inside and complete the plaster into an above knee. You have to maintain the knee at 90 degrees and you have to go reasonably high on the thigh, not terribly high. It's not a toe to groin. You need to leave space above so that, the babies usually wet their plasters. So a slightly lower plaster helps. And this is the final completed plaster. Because we use a thumb in cast technique, we hardly have a problem. We don't have a problem with pressure sores at all on the dorsum of the foot. And we can gain a very quick correction because we can apply a bigger force. So this is a typical case, CTV, a right foot, and this is after the fourth plaster. And here it is again, CTV left foot, and this is the fourth plaster correction. And final plaster requires that you have about 60 degrees of abduction on the forefoot over the calcaneum. The heel has to be maintained in neutral position. And this is an ideal cast. And this is the result. As you can see, the CTV has resolved, but you need this hypercorrection. You need hyperabduction in order to say that you have done a proper job. Usually when the lateral border goes concave, that is the time to do a tenotomy. Though it is on the individual surgeon, I usually try to gain about 60 degrees of abduction before I do a tenotomy if required. If you can get normal ankle dorsiflexion of up to 15 degrees, then you do not do a tenotomy. You just manage it without a tenotomy. And don't forget that once the correction is done, then Dennis Brown comes into play, and exercises are important for success of this technique. Now, what is the effectiveness of Ponseti casting? Initial correction rate is 90 to 100%. And when you look at Goldstein's paper, he says that in 1996, 70% of the kids underwent extensive surgery for clubfoot. But in 2006, as a direct impact of Ponseti casting, only 10% of the kids required extensive surgeries. At 2 years, 86% children are completely well and they don't need any further treatment. And 13% need recasting and 1% go for further surgery. So long-term success with the Ponseti technique is 74 to 78%. And it's a very high success rate. When you look at Ponseti's published results, he had a 30-year follow-up. He had good results in 78%. The most striking thing was that there was a lack of stiffness in these feet and an excellent triceps surae function. And this is a typical example. A kid, 16 days old, then at 6 years, you can see a nice plantigrade feet, fully mobile, and the kid can sit and squat, but the squatting is limited. I see this very commonly. They do tend to stiffen up a little bit as they grow older. But overall, everybody would agree that this is an excellent result with a very conservative technique. Thank you. Do we have any questions?
Yeah, Dr. Sanjay, can I come in?
Yeah,
Sir, stop sharing, sir.
Okay, 1 second.
Yes, thank you.
Dr. Sanjay, I want to know till what age you can do this Ponseti correction?
Yeah, that's, I think, a good question. I usually succeed till about 3-4 years of age, sometimes 5 years of age. If the foot is very stiff, no, not beyond 2 years.
So what are the criteria there, that if if foot is a neurologic, due to neurologic problem, CTV, will this Ponseti technique work?
It depends on what kind of neurology that there is. If it is a lower motor neuron lesion, not much stiffness, for instance, then it may still be supple enough to be corrected. If it is something like an arthrogrypotic foot, then usually they don't do very well with casting, but we must always start with casting and see what kind of result it brings us. Because sometimes you have very stiff feet, and if you persist for 1 or 2 plasters or 3 plasters, they start molding and getting better.
And one more, sir, your opinion, like suppose some person who is not very well trained in Ponseti technique, and he does casting, and he does not do a proper job, and we have a relapse. Should we try it again?
Definitely. See, I will tell you one thing, in all humility, even the best trained people do have relapses. The relapses are more dependent on the severity of the CTV rather than error in technique. This is a very simple technique. There is not much that can go wrong. One thing that can really go wrong is if you really push the foot hard into dorsiflexion and you can create a mid-foot break. That is the scary bit. If it doesn't get fully corrected, no problem, you can try it after a while again. If it relapses, you can try it again. But if it goes into a mid-foot break, that is very difficult to correct. And that I would consider a major complication of this technique.
Okay.
Dr. Sanjay, why start at day 5? Can't we start day 2 or 3?
You see, the baby needs the mother and the mother needs the baby. They both need bonding. The umbilical cord that area is still raw. And it does not really matter. I mean, you can even start at 10 days or 15 days, you'll still get a very good result.
Okay. And secondly, regarding, in an older child, it is very difficult to control. Maybe 1 or 2 month child is okay. But after that, it is a horrible job to apply in the OPDs,
And Dr. Saab, what I do is I use pedichloral. Unfortunately, the current, I don't know which politician, how government, they have stopped pedichloral from the market. I don't know why. Pedichloral is very effective. We give pedichloral in an appropriate dose. The baby sleeps off. We can very nicely apply a plaster. But I don't know which fool decided that pedichloral is to be taken off the market. And they have taken it off.
Then how you get it,
sir? The alternative?
No alternative.
No, I use Finargan, sir, because pedichlor is not available. So I've tried Finargan. It also works, but not as to.
But I'm just pointing out as to the stupidity of this whole thing.
Yeah, I know. I know, sir.
Dr. Sanjay, how you get it?
Markets are right now very difficult. I'm getting it from here and there. I'm asking parents to hunt around, and there is some stock left. I have told the pediatric associations to write very strong letters to the government saying that please allow this pedichloral back again into the market.
Because you cannot give the GA to each and every time,
I am sure there is some foolish IAS officer behind it.
Sir, but Finargan also works to some extent. Not
some
as
extent,
good as,
sir, but basically pedichloral is pedichloral. Yeah.
So, any other comments, sir? Dr. Rajgopal, sir?
I think we are good. I think we should run on to the next topic.
No problem.
Thank you very much for your patience.
Only thing I want to say, Rajesh, is that it's probably the very important topic from the exam point for postgraduates, and a wonderful talk. And I think actually he needed more time. It's a very, very important from the exam point of view. Umpteen questions are asked about this.
Dr. Rajesh, we have been watched in 15 countries.
Great.
I have one question.
Yeah.
You put the thumb inside, holding the talus, and then complete it. Is that done by everybody all over, or
no? This
is it modified by you, or Ponseti himself has suggested?
No. I will tell you there is a story behind this. It is unpublished yet. This whole thing. I've been doing it for 14 years. I was in Allahabad in 2004, and Shafiq Pirani came there, and I asked him. I said, I'm very worried about molding the dorsum of the foot and causing a pressure sore. He said, why don't you put your thumb into cast and mold around it? I said, fine, that's a very good idea. And I've been doing it. I met Shafiq Pirani 2 years ago. I told him, I've been doing this. Do you do it also? He said, I don't even remember that I have ever told you this. And no, I certainly don't. So I think I'm going to write it down and publish it.
Publish it, sir.
It's a good idea.
It is a good idea.
See, preventing complications is the most important thing.
So
it works well. We don't have a single pressure sore.
Yes, excellent.
Okay, then we move on to Dr. Atul, sir.
Sure.
Ready?
Yeah, I'm sure.
Okay, sir. Share the screen, please. Dr. Sanjay, keep on staying. We have some cases for you, pediatric cases.
Is the slide visible?
Not yet, sir.
Not yet.
No.
Dr. Ravi, you have I think it's something.
Yeah, it's coming now.
But we don't have.
Not coming yet.
Can I share it from my side?
Yeah,
sure. You can do it. You can do it.
Dr. Atul, you unshare. Ravi will do it the job.
Okay, I've done.
Maybe some not problem there.
Yes, sir.
Yeah. Great.
I'm talking on different types of plasters. Most of the plasters have already been discussed, but we need to go further and a little history into this thing. The first recorded history of the plaster stiffening was done by the Arabian surgeon Abu in Sina in the 9th century. This is a collection from the Egyptian mummies to show how fracture femur was treated by some sort of a plaster. Next, the modern usage comes to, as discussed earlier by Antonius Megisthon. Next, the plasters commonly used are in the forms of slabs and casts. The upper extremities, we have the shoulder spica, the humeral slab cast, long arm slabs, above elbow cast, below elbow cast, scaphoid cast, and thumb spica. Lower extremity, we have the hip spica, the above knee cast slabs, cylinder cast, below knee cast, and functional cast braces. The braces and spinal cast are EDF cast used in the spine, in the scoliosis, the risers cast, the Minerva cast, the full body cast. A large number of them are not being used. A shoulder cast is illustrated here. I rarely see it, although in my PG days, I did tie casts for fracture clavicles and the upper shoulders. Next. This is the humerus where we have the U slab and the hanging cast, which we use very frequently for this thing. Next. These are the above elbow cast and below elbow cast, which we are using. And these are the limits that we have to use a very good padding and do it to mold it correctly. Next. This is a scaphoid cast. Next. This is the thumb spica. Next. This is the hip spica. The hip spica is of 3 types. One is the single hip spica, one is the 1.5, and one is the total bilateral long spica, which depends on what we are doing. This is the above knee cast or slab, which we use usually for the tibia and fibula. Next. This is the below knee cast and slab, which has a walking heel. These are the cylinder cast and the short leg and the long leg, which we are using. These are the functional braces, the Samento or the functional braces for the lower, for the tibia and fibula. Next, this is the cast bracing which we are using, and this is a method and the final result for the cast. This is how it works finally. Next, These are the special braces like the Minerva cast, which we are using for the spines and for this thing. These are the special casts we are using for the hip in the children. And these are the bivalve casts. The bivalve casts are a very have a great advantage because being covered from both sides, they act as a complete cast and they are a splint because they have a split space. So while slitting a cast, this is a collection of all the casts that we normally would see: a long arm cast, a short arm, a long arm, a short leg, spika, and the body cast. Plaster is the most easily available and affordable treatment modality for treatment in vast populace of India because of our resource compromises, and they give us a great amount of results. Thank you.
Sir, you wanted to show some, your cast.
No,
you apply
the functional this thing I'm using. I can show you a video.
If it runs, sir.
1 minute. But I don't know whether I'll be able to share it. No, achha, I'll just try. 1 second. This is it visible?
Not, sir.
No.
Then I think now is it visible?
No,
sir,
not yet. Not yet.
Okay, I think we'll, sir, take few questions if there are any for Dr. Atul. Okay, now it is visible.
Yes.
So this is what we are doing. I'm using for my a bivalve cast for the forearm. This thing. This is a demonstration that I had made. After padding it well, we make a slab which we double up and then we soak it and then put it. We measure it from the metacarpal junctions to the other height. Is it running fine? Because for me it's running very slow.
Not running, sir.
So I think let's drop it.
Sir, I think okay. To stop sharing, sir.
I'll do that.
I have stopped it, sir. Go ahead.
Yeah, sir.
Okay, Dr. Atul, what you are showing bivalve is also known as sugar tongue, I suppose.
Sugar tongue, yes.
It is the same, right?
Yeah.
It is the same thing, yeah, sugar tongue. There is a single sugar tongue, there is a double sugar tongue also.
Yes, and it is used quite extensively in the US because if you do a Google search, you'll realize that a lot of people are using it there. And for even in post-operative work, it is very good because you have a split as well as a cast because it is a bivalve. You cover it from both the sides, and the issue is very easy to split it and open it up and do a bandage and come out. Okay. And in case of a swelling, it is very easy to split it out. And in most of the remote parts of the country, the problem is you don't get second choice of anesthesia. So you do the reduction in the first thing and then complete the cast after checking your reduction. So it is a very helpful cast for use.
Dr. Atul, can you elaborate on the extent of below elbow slab?
The below elbow slab normally comes round from the junction of the head of the metacarpals, goes around the elbow, and then it comes down to the other end of this thing. What we do is take a 6-inch bandage for the adults and double it. So it becomes about 10 layered. Then you soak it and then you put it. This has been promoted very long back in the early 90s in the BMJ about reduction of the pollicis fracture. And I find it very good even for the forearm fractures to keep a reduction. Only that you have to be a little careful because on the medial side, you have the median nerve going. So you have to pad it very well. Otherwise, there may be paresthesia.
Okay. Any other questions, sir? Dr. Rajpal, sir?
I don't have anything special to ask. No questions.
Okay. So I think mine is the last talk. I think complications of the fracture.
Sir, before that,
okay,
can I ask one question to any speaker? That we have discussed much about the plaster application and all,
yes,
and not much discussed about the plaster removal.
Sir, I am going on that. Wait. Mine, it is in my talk.
Okay, sir.
It is the last part. First we apply, then we remove.
And shape removal.
Yes, I'll discuss that. Can you see my slides, sir?
Yes, sir. Just
yes.
Okay, so after having so much discussion on plaster, let us see now what are the complications of the plaster cast. Very important again. Now we all know now that the function of the cast is to rigidly protect an injured limb, and it serves to hold the fractured bone in a proper alignment to prevent it from displacement while it heals. So regardless of how long the cast is used, to maximize benefits while minimize complications, the use of cast and splints is generally limited to the short term. We cannot continue with the plaster cast with a longer time. Otherwise, it will lead to lot of complications. So it has to be optimum. Now, cast complications can be systemic complications, or it can be a local can be immediate and delayed, and it can occur during removal, after removal, and there are also cast complications in special cases. So we are going to discuss them all. Now there are immediate local complications, which are allergic reaction, constricting effect on the limb, heat injury, skin trauma, pain. There are so many delayed local complications, systemic complications, venous thrombosis, and the cast syndrome. So we are going to discuss them each. Immediate local complications. Allergic reaction, very common. A patient might be allergic to material of the POP cast, the preservatives, and other substances in the cast. Allergies are known to be more common with the newer synthetic cast materials. And if it does occur, we give anti-allergics to the patient. But if it does not subside, then we remove the cast, clean the skin, apply some soothing agent, and if required, can reapply the cast with some other material than was previously used. Don't apply the same material to which the patient is allergic. Okay. Now, constricting effect on the limb. Whenever there is an injury or there is a fracture, there is going to be some swelling. And when we apply a plaster cast, this is very well tolerated by the patients. But if the swelling is more and there is a moderate constriction, there is going to be compression of the veins, damming of the blood, swelling, pins and needles, discomfort, pain, blue color in the skin and under the nails. All these are signs of Walkman's ischemia, impending Walkman ischemia. And the treatment of this is split the cast, elevate the limb. It usually relieves the symptoms. And sometimes you may require fasciotomy. Okay. But if this condition is not recognized and treated in time, you will see this type of the picture leading to Walkman ischemic contracture with its dreaded features. So the important thing is, when you apply a plaster cast, you instruct the patient to keep the limb elevated. Very important. And instruct the patient to move the part which is outside the cast, like toes and fingers, to keep on moving. Okay. And report immediately if in case there is increased pain, swelling, pallor, and cyanosis. This has to be documented on your OPD slip or in your discharge slip. Otherwise, you are going to face some legal issues. So it is very, very important. Now, this is a small video to show what we instruct to the patients. So see here, the limb is elevated. Okay. Synthetic cast has been applied, and we instruct the patient to move the toes like this. Move the toes. Idhar. बंद करो इसको, वीडियो बंद करो. Okay, so it is very important what to instruct to the patient. It has to be demonstrated. Now, coming to skin trauma and heat injury. there are many reasons for the pressure points on the underlying skin. So important thing is improperly applied plaster cast. So there should not be, as I have already discussed, no bunching in the cotton or in the stockinette. There has to be proper padding at the edges. Okay, you have to cover the bony prominent points, pressure points, and you have to mold it with the palm and not with the fingers, and you hold the curing plaster on your palm if required and not on the fingers. All these things will lead to the pressure source and pressure points on the underlying skin. So the most common sites are the dorsum of the ankle, popliteal fossa, and the cubital fossa. So they are the more important points. Coming to heat injury is more common with the fast setting plasters. And when we use a hot water temperature more than 24 degrees centigrade, so there are chances of heat injury. So what is the optimum temperature? It is a lukewarm temperature between 22 to 24. So we should not use very hot water for wetting the plaster bandage. When the plaster layers are more than 12, so don't use more thickened plaster. When you support the curing cast on a pillow, and when you cover your plaster of Paris in a polythene, and when you apply, as already discussed, when you apply the synthetic cast over the plaster of Paris, then there are more chances of retention of heat and heat injury. Now, there are many reasons for pain: damage at injury or reduction, swelling, muscle spasm, pressure on the nerves or vessels, and skin irritation or the sore. Whatever the cause, we have to treat the cause. Coming to delayed local complications, very important are the pressure source. So now causes again: poor technique in applying pressure plaster, local cast breakdown, foreign bodies may fall inside the cast, scratching with the sharp objects, very common. Patient often scratch the skin with the sharp objects like pencil or hairpins. Plaster soakage may wet the cast and cast will break and leads to pressure source. Or cut edges of the plaster. As I have already told you, you have to protect the edges. Now, patient with a plaster sore may report burning, itching, or the stabbing pain. And children may have disturbed sleep and elevated temperature. There may be heat and swelling of the digits, increased warmth over a localized area of the cast, and visible pus or staining of the cast. Now, these are the few examples of the pressure sores. You see, this is one of my patient with a plaster sore. Now, process sores are graded. Grade 1, redness of the skin. Grade 2, involvement of the subcutaneous tissue or cellulitis. Grade 3, involvement of the muscles. And grade 4, it is bone deep. So how to treat? Grade 1, remove the offending pressure. It will heal. Grade 2 to 4 ranges from simple dressings to surgical debridement and reconstructive procedures. Now, coming to loss of position, again very common. Whenever there is a fracture, there is going to be some swelling. And when excess padding is placed under the cast, padding gets compressed, edema subsides, cast becomes loose, and there is a displacement of the fracture. So one may insuate the finger between the skin and the cast. It is so loose. Or you can see this. This is known as Wellington boot effect. So loose a cast, it serves no purpose. And if it is there, you have to change the cast. Now, coming to nerve damage, there are many causes like direct compression by bone ends of the plaster pressure, indirect compression of edematous tissue, tourniquet effect, and reduced blood flow. Patient may have tingling, numbness, impaired sensation, and loss of power. Whatever the cause, it has to be treated. Now, patient can enter your clinic like this: breakage of the cast. Okay, so why it happens? The cast may get wet. There is a persistent pressure on one area. The patient fails to take proper care. Patient falls on casted extremity, and there is a self-repair attempt by the patient. So if it is there, you have to change your cast immediately. Coming to some important systemic complications, deep vein thrombosis, it's the most serious of all, and main symptom is the pain in the cuff. It requires medical attention as soon as possible, and patient can have pulmonary embolism and can die. But it is not very common during plaster immobilization, but it can occur if unnecessarily prolong the plaster duration, especially in those patients who are at high risk. What are the patients who are at high risk? Patient has a history of DVT, obese, diabetes, already taking anticoagulants. Those are the patients we have to be very, very careful. Now, this is the cast syndrome. It occurs in all trunk plasters, and patient may have nausea, abdominal muscle cramps, retention of urine, and abdominal distension. Now, why it occurs? There is an obstruction of third portion of the duodenum by the superior mesenteric artery, leading to high intestinal obstruction. So this is the cause for cast syndrome. And cast syndrome may be prevented by avoiding constrictive body cast that accentuates lumbar lordosis or prevent normal changes in the abdominal contour. So if it occurs, we have to remove the offending plaster, if any, absolute dietary restriction and nasogastric suction, IV fluids, positioning of the patient on left side or prone, and if required, duodenectomy or gastrojejunostomy. Now, complications can occur during cast removal. There may be damage to the skin due to electric cutter, or there may be burns due to heat generated by the cutter. So we have to be very, very careful. Now, swelling, there may be some complications after the removal of the cast. Post-cast edema, very common. After removal of the cast, most of the patients say there is swelling, and if it does happen, the patient should be instructed to keep the limb elevated, do some active exercises, and apply some, elastic bandage for a few days. It resolves. What is fracture disease? Fracture disease is if there is a prolonged immobilization in the cast, patient will have wasting of the muscles, stiffness of the joints, osteoporosis, and some swelling. So how it is to be prevented? We ask the patient to do the exercises of the parts which are outside and even inside the plaster cast. You can ask the quadriceps static exercises and immediately mobilize the patient, or you can switch over to the functional cast bracing. This is how we can prevent the fracture disease occurring. Now, complications of plaster in special cases. Body cast, it can keep on moving down and there may be pressure necrosis over the sacrum or under the axilla, and patient can have cast syndrome. Minerva cast, there may be pressure over the sacrum, coccyx, and iliac crest. Hanging cast, there may be distraction of the fragments and sin problems of the axilla. Arm cast, there may be pressure sores in the cubital fossa or at the base of the thumb. Hip spica, again pressure changes in the sacrum, coccyx, trochanter, popliteal region, and calf regions. Leg cast, prone to breakage, pressure changes around heel, and burning pain in the heel. So how to prevent all this? So application of the plaster cast should be done by a skilled person in a proper manner. Very, very important. Patient as a routine should always be called for follow-up examination next day. Strict elevation of the limb should be instructed. Patient should report on pain that is not relieved, swelling, bluish, or pallor of the distal part. And patient should be carefully examined in the follow-up for probable complications of the plaster cast. So coming to last few slides, cast splitting techniques and cast removal. So most of the postgraduates, they are not knowing this and they are not taught this. So they must know what are these instruments first. So this is the scissor, this is the shear, this is the spreader, this is the saw, and this is the inverter. So they have to be familiar with all these instruments. Now, the jaw of the shear, it is inserted between the plaster and the stockinette or the padding. Okay, between the plaster and the padding. And important here is this part is has to be parallel to the shin. This handle has to be parallel to the shin. So cut it completely. Then you cut your padding with a scissor and then you invert it and spread it. So this is how a plaster cast is cut with a shear. Nowadays, most of us are doing this thing, cutting with a oscillating cast saw. So not very easy. So everything has to be explained to the patient how the cast saw works. It has to be done by the trained personnel. It has to be done by a sharp blade to avoid the heat generated due to blood blade. It only vibrates with little rotation. It does not rotate like a circular saw, so it does not cut the underlying skin. And when the saw gets through the cast, you may feel loss of resistance. It means you have cut the cast. The saw should be lifted, manually rotated slightly, and reapplied further along the cast. So it has to be lifted and again applied. Avoid bony prominences. Padding has to be cut with the scissors. Do vival weaving. If you don't do vival weaving, it is very difficult to separate the cast. It may require 2 or 3 persons. Very, very hard. So you have to do vival weaving and then remove the cast. And patient, if complains of pain, you have to stop doing it. Now this is a small video to show how it is done. See this. We separate the stockinette from the upper part. Then we see this is perpendicular to the cast. Lifting, keeping down. 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 Here. And it has not to be dragged like this. Don't drag it like this. So one step at a time. So this is how this saw is used. Bring the slide back. Okay, so it is very important to know how the plaster is cut, Now, it sometimes is difficult to remove in children, due to anxiety of the parents and the children and the fear of the oscillating saw. So, avoid using synthetic or semi-rigid material in children. Only apply POP cast. And there is another way to remove the cast in a child. You dip the casted part in a lukewarm water, wait for about 15 to 20 minutes, and then you can remove the softened POP material. So this is how we do it in children. Thank you. So this is all about my last talk and the last talk of the session of this webinar.
Excellent lecture, Dr. Rajesh. Very nice.
So if any questions or queries about this, we can discuss. Otherwise, we go to the few cases only. I have restricted to only 3-4 cases, not more than that. Any questions on this or any comments?
No, thank you. Excellent talk, sir.
Usually the
any instruction to the parents?
Yes, I have already discussed, sir.
Parents to parents.
I have already
in
discussed.
Emergency, how to remove the plaster.
Yes, already told.
So in the emergency, we have to
home,
do it.
They are not trained.
Yeah, either we have to do it ourselves in children, But in children, the important thing is we ask the patients, attendants, or to soak them in,
Yes,
home also.
Yeah.
But in emergency, it is ourselves we have to remove it. Don't let it to the technician to remove the plaster in children. That's what I do. And you are saying instructions to the parents. They don't have to worry about all those things. They have to told the child may cry a bit, but then it has to be done. Any other point in your mind, Dr. Harshad?
Yeah, there are several things, but then we have no time for discussing so many things.
You can carry on with the 1 or 2 points, no problem.
Yeah. One is I never put a complete cast. I put only slabs for all emergencies.
That is already discussed, sir.
Yes.
Sir, it is already discussed.
Second thing, the medico-legal aspects of these things is very, very dangerous. A small
I have already
and
discussed.
Then you put a cast.
I have already discussed, sir, in my first.
I know. I'm not saying you are not discussed.
No.
The important part. Your lecture covers most of the things.
No.
There's
Anything extra, sir? Anything
more.
extra? And any other important point enlightening us?
Otherwise, you have covered everything, all aspects. We are in details.
Okay, thank you very much. So we move on to a few of the cases, next slide share. बंद करो, close down. ये नहीं. Just a minute.
Till the cases come up, I think the extent of the cast for various situations
has
not been discussed. But depending on the type of injury and type of immobilization required, from where to where we have to put the cast.
Yeah, important thing is, I have already asked Professor Atul the same question, for below knee, below elbow cast, we have to go from the metatarsal heads, proximal crease, and proximally it has to be 2 finger breadths below the flexion crease. So this is the important aspect, the extent of below elbow. For above elbow, we have to go above the, just below the axilla. We don't have to go up to the axilla. So these are the few things,
Basically, you have to see the most muscular area where the cast will not come. That's the basic idea of the upper limit, especially in a single bone.
Yes, yes. Okay, so this is my first case. This is a 3-year-old child, fresh injury. Any comments, sir, Dr. Atul, how to move out this?
3-year-old child, any way would be hip spika.
So yes, so there are ways we can go for a skin traction for 3 weeks and then hip spica, or hip spica, straight away.
Or a combination, traction and plaster.
Yes, but the important thing is here how to apply, spica here. Whether you give a traction or straight away like this.
No, it will be always wait for the swelling to come down, and then it will be 1.5 hip spica, where we'll need to keep the child. I usually keep it on a fracture table and then have a minimum traction, so as to maintain the length and to keep it in alignment. Because normally these bones will fall in place, especially a fracture like this.
Yes. Dr. Sanjay, any comments, sir?
Yeah, I would broadly agree. You need to apply traction till the child becomes painless. That usually takes about 7 days or 10 days. You usually test it by gently palpating the thigh, and if the child is not painful, that is the best time to put them in a hip spica. 1.5 spica, as Dr. Saab said, is fine. But you must give it time. You should not immediately put the child into a spica. That would be a big mistake. By putting traction and then giving hip spica has advantages because it reduces the amount of shortening. It does not create a wide displacement, because the wider the displacement, the more time it takes to recover from it. And it is much safer also from aspects of compartment syndromes and other things.
But sir, so if the child comes immediately, within hours, even then we give traction and then
you must. That traction is to control the whole situation. It's a major limb fracture. There is a lot of muscle spasm. There are many things, and if they are in a hip spica also, they are very painful. Sorry.
And reduces the edema as well. And you
yes,
can,
there are so many things that happen, and you can keep and watch on it. You must put them in traction. Nobody should acutely put a hip spica for a fracture like this, unless and until it's a green stick fracture. Yeah. A fracture like this, definitely always put them in traction. Let them come out to, whatever reasonable. It doesn't matter what length you have. It doesn't matter what angulation you have. It is just to stabilize the bone ends a little bit with some soft callus, and then you put the plaster.
Sir, issue is, suppose we have to do the reduction, while applying, there are in places we don't have a fracture table of the child's, size. And yes. How to do the traction while applying the spica?
Sir, you don't, once you've taken them up on the 7th day, as I usually do, or the 8th or the 10th day, you don't need to apply traction. You just apply a hip spica. And I usually do that in a human position again. But if you are going to reduce this, then you will need a lot of things. However, having said that, a 3-year-old child, there is no advantage to reducing a fracture.
Okay.
Sir, in this case, usually we find usually it ends up with the little shortening
Yes.
if you treat it conservatively.
Yes.
But in course of time, the length is made up.
Yes,
it is
absolutely.
corrected.
Absolutely.
But during this period, it is very difficult to manage the patient's relations.
No, it's not. I've never had a problem. I always tell them that a little bit of overlap is desirable, because if we don't overlap, if you reduce it anatomically, this limb will become longer than the other one by a centimeter.
This is well documented, I think. This is well
Yeah,
documented.
it's not. And if it's the left side, it's 1.5 centimeters, right side 1 centimeter, and they understand. And there is no problem. Usually 1 centimeter gap, a child has no problem. He just limps slightly, and they know that it will become okay, so they are fine.
No, not always the patient's relations will agree, but they think that it might cause a problem later on.
Well,
it is very difficult to convince.
It's a
That's
matter
I'm
of,
telling you. This is
it's
the
a matter,
practical
yeah,
point.
that's what, I mean, this has been my experience. It's a matter of counseling. It doesn't matter. I mean, medically, that's the right thing to do, just to apply a hip spica, not bother about the reduction. Alignment should be good, desirably good. But even though alignment may be off, they remold so quickly that it's never a problem. However, having said that, it's good practice to get a good alignment, and that comes with waiting in a traction for a few days. If it is a small baby, you can give gallows traction. If it is a older kid, you must flex the knee and give a flex knee traction over a pillow or something, whatever is suitable in your environment. But when you give traction, it's usually a skin traction, so you must be very careful with the skin under the below knee traction. Dr. Harshit? Yeah.
Sanjay?
Yeah.
So we move on. So Sanjay, forgive me. I applied this acutely, in my clinic.
No problem, sir. That's beautiful. It's beautiful.
So I just give a traction, up to knee first, above the knee, and then I just made up the things later on.
Yeah, it can be done. It can be done.
Yeah. So this was
to
done,
Dr. Sanjay.
Yeah.
One question to Dr. Sanjay.
Yes, sir.
Yeah, which such fractures do you decide to put a tense nail?
When they are more than 5 years old or 6 years old. Up to 5 years, I don't put any nails. Below that, it's just a hip spike.
Sanjay,
I never nail them less than 5 years.
Sanjay, should I practice this or leave it now?
Sir, you have to
acutely.
Acutely. Don't do it, because you might have problems.
Okay, thank you very much. I'll follow your advice.
Thank you, sir.
And this was after 6 weeks. Lot of callus.
See, that's what I mean. You may reduce it perfectly, it will slip inside the plaster.
The only thing is, what we are seeing is the AP view. No, we never take lateral view.
Sir, you may have reduced it fully. It may have slipped later on.
Yeah. So this is
only thing is the rotation. Only the rotation to take care.
Rotation, you have to take care. Yes.
Yeah. So this is the first case. So
this is child will be 100% okay.
I know. Thank you very much. Sanjay, again a pediatric case.
Dr. Rajesh, sir. Just take question related to your presentation.
Yeah.
There is a fracture femur in a child below 2 years.
Yeah.
Do you still use gallows traction?
No, I don't use gallows traction, never. And I have never used it.
Okay.
I have never used it. Dr. Sanjay?
Yes, sir.
Dr. Manish, query?
I use gallows. Yes, I do.
Okay. So, Dr. Sanjay, this is the second case. This is a child, 11 years. When the child came to us, he was having different position. This was the first X-ray available with the child. So this is a supracondylar. This was the only X-ray. This was the only view available with the child. With the parents, and it looks like a supracondylar fracture humerus.
A fresh supracondylar.
Yeah, at the time of injury.
Right.
Now he went to massagers and all those things. And he came to us after 6 months of the treatment by massagers. Now we know that the treatment of fresh injury is close reduction, pinning, or open, whatever. Right, Sanjay?
Right, sir.
So, but he never got all those things. And this is the picture after 6 weeks. He had all the X-rays done. I don't know who was advising the X-ray to the patients. but he had all the X-rays, but he never consulted orthopedic surgeon. So this was the 6 weeks. Should we do something here or wait?
You have to wait, sir.
We have to wait because a lot of callus is there, myositis is there. Although it is fully displaced, Garland 3, we can say it.
Yeah,
so
yeah.
It is fully displaced. So
But
we move quickly, another 6 weeks. So now this is the beauty of the nature, everything is remodeling. Everything is remodeling. So this is a nature.
Flexion block might be there.
This is, or wait, sir, wait. So this is the nature, nature doing. Even if we don't do anything, the nature has to unite the bone.
Sir, Malishwala is also doing something there.
Yeah, this is a Malishwala, na sir? Yeah, this is a Malishwala. That is why a lot of myositis.
Exuberant
yes,
callus.
Yes.
Yeah.
But then it remodeled, and see here, picture is getting a bit clear.
Yes.
Now remodeling is happening, and all those things are going down.
You see, but one very nice thing I noticed right from the beginning, there it seemed to be rotationally well aligned.
Yes, sir. So this is the time when the child came to me.
Okay.
This is on 15th of March, everything is consolidated very, very well. And he has this much, this is the flexion and this was the extension. Should we intervene now or wait more?
This is how long?
6 months.
6 months. You can wait for another 6 months, sir. This is my personal opinion.
Yes.
Elbow growth ceases after age 8. So there is not much growth left in the elbow. Although we would like the physis to grow away from that block and give him more flexion. Usually by the age 14, definitely there won't be much left. Though skeletally he looks less than 13. However, you can wait for a year and
he's
then
11, sir. He's 11.
11. उसपे 13 लिखा था.
13
पता नहीं.
हाँ 13 sir.
13 लिखा है. So you can wait for some more time. You can wait for a year. There is nothing lost in that. And this is my again personal opinion. You just have to excise the bony block and he'll be fine.
So we did nothing, sir. We are waiting.
Yeah, absolutely.
I think he lost to follow up also, but I advised him to come again.
Because he'll be happy with what he has.
So the treatment done by the bone setters. So.
Sir. And the only thing is that when he's nearly ready to get married, he'll come back to you and say, "Ab ye deformity theek karo."
Okay. So any comments from the other faculty? So we move on to the next, this is a very, very interesting. This is a 45-year-old, patient, mentally retarded, emaciated. And when he came to my clinic, there was a 1 by 1 inch infected wound over here. And bone was just protruding out. Now, what are the different options at this moment? Anybody? Dr. Manish?
Yes, sir. So what is the age? Age is
45.
And there is an infected wound?
Infected wound and bone just protruding out.
So I will basically first go in for debridement and removal of the exposed bone, and I will put him on a orthofix, my personal choice, or a external fixator, and not treat it with plaster. I avoid treating with plaster.
When I saw the patient, patient was so emaciated, I thought he's not going to have, tolerate any anesthesia.
Okay.
He was mentally retarded patient. So what could be the other options?
Mentally retarded, I will avoid. I think I did not hear that, because I will avoid any metal thing to be put, because they can injure themselves.
Yes.
So probably I'll debride it and nicely and give it a recast again, because I have to debride and close.
Patient has not got any treatment till date. No treatment.
Okay.
And any other faculty want to contribute?
See, the basic issue is because he is mentally retarded, his functional uses of his joints may be very limited. So even if we just clean it out and maybe give him a splint or some sort of a slab or something and hold it for some time and let it unite, because basically immobilizing any of his joints would lead to more problems than solve problems for him.
Right. So what I did was I debrided the wound in the clinic itself, and then I gave this splint to this patient. This is the only thing given. And when the patient reported back to me after 1 month, this was the picture. Okay. This was the picture, and this is the what we were discussing of functional cast bracing. But why functional class worked here, I don't know, because I advised the patient to remove the splint after debridement after 1 week. If he daily removes it, then there is an issue with the functional cast bracing. And this was the picture, see how emaciated it was. And when he came to me, it was completely healed. There was no wound. It was the last dressing they had. And it was united. Any comment, sir?
Maybe a humoral factor, like in head injuries, you have faster unions, maybe mentally retarded, his activity healing may have been better.
I don't know.
A lot of cases of polio, old cases who have had fractures, and it's almost something like putting in a saving the joints and putting a cylinder, and yes, they usually unite.
I don't know. Maybe patient is lucky, no infection, and it united. Any faculty want to come in? Okay. So we move on to the last predatory case. So this is 20 days old. Here it is written. Here it is 20 days old child. Fracture shaft of the femur. Dr. Sanjay.
Sir.
This child came to me, army person's child, very apprehensive. Now we know the options here. We know the options. We can give pelvic harness or any slab or whatever, it will unite.
Sir,
what are the
yes, I mean, this needs a hip spika. That's the first thing, but that's the part of treatment. One thing is there, it's a transverse fracture. So how did the injury occur? That you have to verify. Was it a fall? Did someone hit the child, or is it a child abuse? Those things you must rule out beforehand. The other thing is that I would again put them in some gallows traction and wait for a few days.
Sir, 20 days, sir, gallows traction?
20 days. No, 20 days. There are, for a 20-day-old baby, no, not at all. 20 days, I don't give pelvic harnesses, because I think, and this is my personal opinion, that it's completely wrong to give a pelvic harness in a fracture. That is because giving a pelvic harness goes against the principles, all the principles that you hold for treatment of fractures. That means immobilization and splintage. Pelvic harness does not immobilize, does not splint. And it allows the fracture to move. The baby, poor baby, lies quietly so that he doesn't get pain. A pelvic itself does nothing. This is my personal opinion.
Okay.
We used to have a time-honored method which went into disrepute before. We used to put a pad in the popliteal fossa and we used to tape the tibia and the femur together. It went into disrepute because people got big skin lesions and urinary soakages and they could not manage it. But a 20-day-old baby, that is my treatment of choice. I put a little pad in the popliteal fossa. I use micropore tape and I tape the tibia to the femur and put a bandage on top. But my condition is that I usually change the tape every 3 to 4 days, and this has to be maintained only for 12 days or maximum 15 days. And the fracture becomes sticky, and then you can let it go and the child is fine. And I have not changed my practice, even though it has become very fashionable to apply pelvic, because pelvic does not make any logical sense to me. A baby at this age cannot tell you he is in pain. So we cannot disregard the pain. We have to splint them properly. If you splint them the way I have described, you will see next moment baby is easy and good. Whenever I have applied a pelvic, I have always wondered, they're just lying still, holding themselves because they are still in pain. Pelvic does not do anything. It's just one of those fancy things which many people write about, and fashionably so, but it's useless.
What about other things, sir? POP slab or thigh
See,
chest bandage,
at
abdomen chest bandage.
20-day-old baby, it's very difficult to do all those things. There is stool, there is urine, there is little baby, very difficult to manage. Best thing to do is to just tape the femur to the tibia.
Okay, but what I did was, as I applied slab, and this was the picture after 2 weeks.
So slab is still, I would say slab is still better than Pavlik harness. It has at least immobilized the baby to some extent. I hope the slab went right up to the trunk.
Yes. I applied long slab.
Yeah, long slab from ankle to the trunk with the knee inflection. That's fine by me. No problem. You can do that.
But then the issue was the parents were worried about this,
Again, counseling, sir. You should tell them, I guarantee you that this leg will be totally straight in 1.5 years.
So I counseled him that army man was not willing, He says, now what else you can do here? I had no answer, again counseling. You say counseling.
Yeah, just counseling. Just counseling.
Tell him Dr. Rajesh, sir. Dr. Rajesh, is there any role of spika at this point? Like at 20 days?
Sorry, no, sir, no. Already, no spika.
No. You had put a slab. But can we apply spika in such a small child?
Sir, very difficult. I don't know, Dr. Sanjay.
No,
very
sir,
difficult.
No, sir, you can't. You should not.
Very difficult to apply. So
I think the counseling is you have to counsel the patient, because everything after a year or so, everything will be everything will be okay.
Yeah. Normal.
Counseling is the mainstay in all pediatric patients, because the basic issue is that X-rays everybody can comment. The moment somebody has an X-ray, he'll tell you what wrong is there.
Problem
So
is we must, since it's a PG teaching, we must tell the PGs that you should refrain from criticizing everybody else's X-ray,
which is very common,
because that is the thing that creates a big problem. And they should remember that those who live in glass houses should not cast stones upon others.
Yes.
And so if that is done, then half the problems will be over. It's absolutely fine to have an X-ray like this, and it will be totally okay.
Okay, I think that was the last case. If anybody has some cases, can discuss. Otherwise, Dr. Manish?
Yeah, I think everything is fine, and we are almost 9:45.
Yes.
So time passed, 3 hours and 45 minutes just passed. It was so interesting that, and I got very good reviews for this whole program from all over India. People are messaging me, they found it very useful, because this plaster technique is one of the neglected things. Even our postgraduates, this is a proper training for the postgraduate. It's a very important thing. I think the basic. So good reviews all over India from other medical college. I got some good reviews from, Andhra medical colleges and down south. So they appreciate that. And whole credit goes to you.
No, sir. It is not like we are all for teaching. We have to teach the students. That is only aim. But I must thank everybody. Dr. Manish, Dr. Ravi, Shamshul. Dr. Sanjay, I must specially thank to him. He is all along with us.
Thank you, sir. Always a pleasure.
I know. I know. Whenever I call you, you are always there, sir. It is
today
privilege.
I almost did not make it.
It is privilege. No. It is always a privilege to have you with us.
Right, sir. Always a pleasure, sir. Thank you.
Thank you, sir. Thank you very much.
Thank you, Dr. Dhawan. Thank you, Dr. Rajesh. Thank you all, faculty.
Dr. Shamshul, can we go off?
I must thank
Manish.
Everybody.
Give me a minute. Thank you, Dr. Rajesh and the whole team. Dr. Sanjay, Ratul is still there. And thank you all. First of all, it's a very important topic, like you said. Dr. Sanjay, I was pretty hurt when a very senior professor, but half my age, commented I had treated a female child by conservative, I gave a spika, and it's common children criminal to immobilize. Children are the ones who tolerate immobilization. So people don't have the concept of remodeling, and it's got a good audience, and I hope they understand the children got a fantastic remodeling capacity. Even the femur you have shown, within not even 1.5 years, within 1 year, they will remodel to a great extent. The parents need not complete 3 months, 6 months to show a difference, they'll be happy. So thank you all very much. It was a wonderful program. And I thank all the faculty and all the people who were with it, Manish, coordinators, Ravi, everybody. Thank you all.
Thank you, sir.
Thank you,
sir.
thank you, sir. Thank you.
Stop the live stream.